Thank you all for coming to our 2023 mini critical care symposium. I really appreciate everyone, coming and showing up for a nice little day of learning. Please, like I said before, scan this QR code or type in the URL, or I also put the URL in the chat, which we'll be monitoring on and off, just to make sure you get your pre-test done so we can get those CEU credits. Does anyone have any questions before we begin? Yeah, it's on. So like I said, welcome again. For our welcome remarks, we have our wonderful CNO, Denise Shepard. I'm so glad you're able to join us here today, as you enter your second year of being our CNO. So give a round of applause for Denise.
Good morning, everyone. Happy Nurses Week to everybody in the room and online. It's been a good celebration week here at Newark Beth. Nurses so often focus on just taking care of our patients, but today is a good example of all the other roles we have to play for professional development and for developing one another. It's so important that we continue to build our nursing knowledge, and so important that we share it with one another, because it all moves us in a great direction. And this is a perfect example of nurses training nurses. And to our physician colleagues who are assisting today, thank you. I want to give a special thank you to the committee chairs or coordinators here. So Alana Barkley from Nursing Education, and our nurses from C8, Olivia Mertz and Sandra Adapt. Is Sandra here? Yes, thank you. This doesn't happen without you and your committee, so thank you very much. I hope you all have a great morning and you learn a lot. But remember, this is about celebrating nursing and all the wonderful things that we do every day. So take what you learned today and pass it on to a colleague. It's important information. So without further ado, I'll let the program get started. Thank you.
Thank you so much, Denise. It's so great having you as a CNO. So our first presenter is someone very special. We have Dr. Vakharia, one of our medical residents here at NBI. She's unfortunately leaving us to pursue her dreams of being a pulmonary critical care fellow at Brown. So I'm really happy to have her here today. We've known her since intern year, and it's so nice to see them grow throughout the program, especially, she started as an intern, as I was just getting my feet wet being a new nurse. So it's kind of nice to see us both grow together. So give it up for Dr. Vakharia.
Oh yeah, none. All right. Good morning, everybody. I'm Shreya. I'm one of the third-year residents, as Olivia introduced me. I think I've worked with most of you guys here. And before I start, I just want to say a big thank you. I know you guys saw me as an intern when I didn't even know how to put Versed pushes in. Okay, and I know Bing called me out on it multiple times. I don't know if she's here. And then, even Christine was being a little patient with me, but, she lost it a few times. But, the point of this talk is we are a heart and lung hospital. We take care of a lot of our patients who have heart failure, whether it's compensated or decompensated. So this is very interactive. Please ask questions along the way. We don't have to do questions at the end. And the whole point is with this talk, we equip you to kind of understand our notes a little better, because there's a lot of stuff that we write in our notes, and I know you guys read them, and then I know a lot of you guys have questions and come up to us and ask a few questions. So this presentation is directed more towards that. Okay. I wish I had financial disclosures, but I have none. All right. So the objective of this talk is going to be, first, let's talk about what the latest definition of heart failure is. How do you diagnose heart failure? It's going to be more useful for us when we get into the classifications and the pharmacological therapies of heart failure, and then how heart failure with preserved EF is a little different from heart failure with reduced ejection fraction. And then I know Dr. Gidea is going to talk about cardiogenic shock, but just to touch over a little bit about the medical management before you guys go full blown into cardiogenic shock. All right. So, ever since, even when I was an intern, the heart failure definition kind of went through a lot of ups and downs. They said it was a clinical diagnosis, and then they said, no, you also need some lab values. So ACC in 2022, with their latest update, came out and said, this is what the definition of heart failure should be. It's a complex clinical syndrome. You should have signs and symptoms of heart failure, be it your dyspnea, be it lower extremity edema, abdominal distension, but then you also need laboratory evidence of heart failure, and that you will get through your elevated BNP levels, and or you can have objective clinical findings of heart failure, like, a chest X-ray with pulmonary congestion, a CAT scan with pleural effusions, or, if you have a swan in, maybe a wedge pressure that's high, so it's not only just clinically, just looking at the signs and symptoms, you also need laboratory evidence for heart failure. And keep in mind that BNP levels are great and they're very, very sensitive, but there are two things that are going to affect your BNP levels. One is obesity. They did a lot of studies and they found that a lot of these obese patients, when the weight went over like 120 kilos, the BNP levels stayed kind of in the 200s, but despite that, they had florid heart failure. So don't always rely on your BNP levels in obese patients. And the second thing is anybody who's taking Entresto. So the way Entresto works, it's going to lyse the neprilysin, so your BNP is not really going to go high. In these patients, you actually need to check your pro-BNP levels. And pro-BNP is like a send-out test. It comes like 24 to 36 hours later. So you kind of admit these patients, but you always send for the level, and then you kind of go from the pro-BNP levels. Okay, so just something for you to keep in mind. So don't let any of the ER nurses tell you, yeah, the BNP is low, but the BNP is going to be low if they're on Entresto. Okay, so that's one thing for us to know. All right, so this is more about like how we diagnose heart failure. This is going to be more so in the clinic, but more and again, we see one of these patients in the ICU or in the CCU when, they have lower extremity edema, they haven't been diagnosed with heart failure, and then we're diagnosing them in the hospital, okay? So the first thing always is your clinical history, right? Patients will come in and tell you classic things. Doc, I could walk like 10 blocks and now I can only walk 2 blocks and 3 blocks. And I'm getting winded, even like getting out of bed, doing things in the kitchen, so that should kind of alert you to start thinking about heart failure. And then that's when, they come to us in the clinic and we send for BNP levels, and the BNP levels are kind of high. And if we are convinced, we don't even wait for the lab test. We send an echo right away, and then the way to diagnose heart failure is, I know we get fixated on the ejection fraction, but it's not always that, right? It's to look at what the left ventricle is doing, to look at the right ventricle is doing, and what the valves are doing, So the 3 major components that you want to look at on echoes, when you guys read the echoes, is the valves, is the ventricular function, and the ejection fraction, okay? And now we have a new classification that kind of is the latest classification that we use: heart failure with reduced ejection fraction, heart failure with moderately reduced ejection fraction, and heart failure with preserved EF. So anybody less than 40, reduced. Anybody between 40 to 50 is going to be moderately reduced. And anybody with an EF of more than 50% is going to be preserved. Over time, with therapies, the heart failure may recover. And remember, we're not going to use the same term for them. They become heart failure with improved ejection fraction. So you're going to start seeing a lot of that in our notes too. And that's what it means. It means like they were probably reduced. And now with time, the EF improved. So that's why it's going to say HF-IMP-EF, which means it's just improved ejection fraction. Okay. So, it's very important to talk about the classifications of heart failure, because the classifications are how we tie in medical therapies. So there's 3 classifications that we're going to focus on today. There's a lot, but I think these 3 have been validated by all the heart societies. And the ACC and AHA actually recommend classifying your patients with the NBIMC classification, which is like a functional classification based on what the patients can do. And then you start getting into staging heart failure. And then I think Dr. Gidea will talk about the SKY classification, but we'll just touch on it because a lot of our patients in the CCU actually have cardiogenic shock. Okay. So let's talk about the functional classification. You can see from like class 1 to class 4, class 1, the heart is healthy. As you start getting into class 2, 3, 4, the heart progressively starts getting, fatigued and tired and really can't do a lot of activities. Okay. So class 1, it's any patient who can do most physical activities except for like strenuous activities. Like let's say, even I get tired when I have to go uphill, but I don't have heart failure. So those are all your class 1 patients. We don't see a lot of our class 1 patients in the hospital. We see a few of them in the clinic, okay? So what we see on the floors is more the class 2, 3, and what we see in the ICU and CCU is more the class 3, 4. Okay, so class 2 is going to be, they have slight limitation of physical activity. So, they could initially do their groceries, but now they're having trouble doing their groceries. They can't carry both those bags up a flight of stairs. That's when you start getting into your class 2. Class 3 is like they can't do any of their ADLs, start getting winded when they get out of bed. Even when they go to the shower, they're starting to get winded. They get tired. They have to take multiple breaks. And class 4, they can barely get out of bed. Can anybody identify a problem with this classification? What do you guys think? Like, this classification is appropriate? Yeah, so that's what we thought for the longest too. But then we realized that let's say patient X, Mr. Jones, he takes his medications. He's very good with what he does. He's always euvolemic. He comes and sees us in the clinic every 3 months. There was this time when he was like stranded and he couldn't get his medications for, let's say, a week. Okay, and then he started getting progressively fluid overloaded. He didn't have access to his Lasix, his metoprolol. And 1 week later, he came to the hospital and he could barely even get out of bed. Okay, that would make him a class 3-4, right? But normally when we see him, he's a class 1. And now as you diurese him, he gets better and he goes back to kind of being a class 1-2. So what the Heart Society's identified is like these patients kind of keep yo-yoing between the classes and they don't really know. So, you can tell them, oh, now you're doing good or now you're doing bad. So the patients get confused. And sometimes when they get confused, they don't take their medications like they're supposed to. Okay. And then they said, heart failure is as serious as cancer. If we can stage cancer, we can stage heart failure. And that's where the whole ACC-AHA staging classification came in. The beauty of this is, do you see the arrow at the bottom? You only go one way. So if you're a stage 1, you stay a stage 1. If you're a stage B, you stay a stage B. If you are a stage C, you never revert back to being a stage A. Okay, you stay that particular stage. So we'll spend a few minutes on this classification because of a lot of our therapies are based on what stage and what class the patient is in. So stage A is anybody in this room, anybody who has high blood pressure, anybody who may be obese, anybody who may have cholesterol problems, strong family history. That makes you a stage A. Okay, so all our patients with hypertension that we see, they are stage A heart failure. What is stage B? Stage B is you have I think you have the recipe to get heart failure, but now your heart is also kind of starting to show signs and symptoms of heart failure. And what does that mean? It means that maybe the LV is getting enlarged, maybe the mitral valve's kind of failing. Okay, so when on the echo you start seeing all of these things, that's when you get into your stage B. Stage C are all patients in the hospital. Anybody who has current or previous heart failure symptoms makes you a stage C. And that is your symptomatic heart failure. And that's what we see on the floors. That's what we see on the tele floors. That's what we see in the CCU, in the ICU, everywhere. And in the CCU, we also see stage D, which is like advanced heart failure, where despite their medications, despite everything, they're still fluid overloaded. They're not doing well. They can't get out of bed. And they're being evaluated for either a transplant or advanced cardiac therapies. Okay, so it's important for us to understand this. So once a patient is stage C, he always stays stage C. He never goes back. All right. So this is just a little cartoon, which I thought was like interesting because it's true. Like we talk about like all these medications and everything. And ultimately the attending and the resident decides, okay, so 40 IV Lasix, like that's us. So, heart failure is so much more than Lasix and metolazone and all the diuretics. So let's talk a little bit about how all of these heart failure therapies came into being. So I think the best example I like using is Dr. Cohen. Dr. Cohen claims that when he was a resident, the only medication available for heart failure was digoxin. And obviously, like not even a lot of our patients are on digoxin, so like over the years, heart failure has undergone a lot of studies. It's actually one of the most studied medical conditions, not only in the cardiac realm, but also in the realm of medicine. And, earlier in the 1980s, ACE inhibitors were starting to get studied. It was not until like the late 1990s where beta blockers, which is like the mainstay of treatment for heart failure, kind of started to come into being. And then, they studied the mineralocorticoid receptor antagonists, the ARBs. Between the early 2000s, they studied the defibrillators and the cardiac resynchronization therapy also. And that they started doing a lot of trials. And by the 2010s, they were validated pretty well. And then the landmark study, Interest, that everybody loves, came out in 2014. And then since then, we've still had smaller studies. And the new wonder drugs on the block, they've been studied, and those are the SGLT2 inhibitors, and we'll talk briefly about them. But the only other things that happened after 2014 was like study on the SGLT2 inhibitors, but this is like a nice way to see like over 20 years, there's been so many new medications available for heart failure. All right, so if anybody tells you about the cornerstones of heart failure, they are the 4 medications that we know, and those are your ACE inhibitors, your angiotensin receptor blockers, ARNIs, Entresto, or it could be your beta blockers, your mineral corticoid receptor antagonists like aldactone, and then your SGLT2 inhibitors. The reason I put this here is this is from the ACC-AHA, and you'll see that they are all class 1A recommendations. Okay, so no drug is better than the other. They all work differently, and you can see that they all actually have mortality and morbidity benefit. But with beta blockers and SGLT2 inhibitors, you're starting to see they even reduce hospitalizations. Okay, so this is why these drugs are going to be your mainstay. And there's so many other medications available for heart failure, right? A lot of our patients are on Bidil, a lot of our patients are on other things, right? But the idea is that you maximize these medications before you even go to those second line medications, because this is your first line. All right, so, kind of talking a little bit about the important pearls, what we should be careful of when we put our patients on these medications. When we talk of ACE inhibitors, angiotensin receptor blockers, and ARNIs, one thing that we need to be very mindful of is when we're switching them from one over the other. Sometimes Entresto is not covered by all insurances. So our patients end up being on lisinopril, losartan, or any other ACEs and ARBs. And when, let's say, we pre-auth it and we get it approved, how do you switch over? And this happens in the CCU a lot also, and that's why I put this here. With ACE inhibitors and Entresto, whether it be lisinopril, captopril, enalapril, whatever you're using, you can get really high levels of bradykinin that can potentiate your angioedema. So you need to have a washout period of at least like 36 hours between the two. But with losartan, you don't need a washout period. They were on losartan yesterday, they can be on Entresto today. It's the way that their mechanism of actions are that you need to, and this is where, you guys could be careful and be like, oh, this patient was on lisinopril yesterday. I don't think we should start the Entresto just yet. We have to give it time for the washout period. So that's one of the most important things. The second thing is beta blockers. Metoprolol and carvedilol are comparable, but a lot of our patients have COPD and asthma. So you don't want to use carvedilol for those patients. And the reason is metoprolol blocks your beta-1 receptors. Carvedilol blocks your alpha and beta receptors. And when you're an asthmatic, it can cause further bronchoconstriction and can worsen it. So you just want to be very careful, and you want to use metoprolol for these patients. I think the residents do a good job of kind of identifying that, but always things are missed. So if you guys are looking through the histories and you see that the patient may have, let's say, COPD or asthma, then just bring it to the attention and we can switch it to metoprolol for these patients. The third thing is the mineral corticoid receptor antagonist, that's aldactone. We know to avoid it in GFR less than 30 and in potassium levels more than 5.5 because they haven't been studied. There's worse outcomes when you use it with a lower GFR, so just avoid the use. And then the new wonder drug on the block, that is SGLT2 inhibitors. So when we were starting out as residents, they said that SGLT2 inhibitors were for diabetes. And then like 3 years later, now they're saying that SGLT2 inhibitors are actually a heart failure drug that just seems to work for diabetes as well. Okay, so I think 10 years, now there's a lot of research happening in chronic kidney disease, and like 10 years later, they're going to cure cancer. So, I think it's very important for us to know about SGLT2 inhibitors. The one contraindication to SGLT2 inhibitors is DKA. And these patients are not going to be your classic DKA. Their finger stick is not going to be like in the 400s, 600s, 900s. They're going to be euglycemic DKA. So they can have a finger stick in like the 150s, but their bicarb could still be 10 and they could be florid DKA. And that is the only contraindication. So if they were admitted to us in the ICU with DKA secondary to SGLT2 inhibitors, they can never get them. That's like their allergic contraindication. So I think that's something for us to know. And then SGLT2 inhibitors have not been studied in a GFR less than 30 or on patients on hemodialysis. So we really don't use them for those patients. This is, so remember the stages that we spoke about? So they say that if you are stage A and stage B, just risk factor modification. Okay, so if you're hypertensive, control the blood pressure. If you have diabetes, put them on an SGLT2. If you have coronary artery disease, treat the coronary artery disease. Do a cath, open the blockage, put them on ARBs, beta blockers. And even for stage B, even if their left ventricular ejection fractions like 30 to 40%, just put them on ARBs and ACEs. Where we come into play is stage C. And this is going to be the slide that is going to be most important for us because a lot of our patients are here. And just how we saw, anybody with heart failure with reduced ejection fraction, that is an EF less than 40%, all of your drugs are class 1 recommendations. And look at where Lasix is. It's right at the bottom. Okay, so before we decide to maximize the Lasix dose, you want to make sure that they're on an ACE inhibitor, they're on a beta blocker, they're on a mineralocorticoid receptor antagonist, and they're on an SGLT2 inhibitor. And then, despite all of this, if they don't do well or if their EF continues to stay low, then you want to evaluate them for the implantable devices. Okay, I just want to talk a little bit about the two implantable devices, the defibrillators and the cardiac resynchronization therapy. Okay, so the idea is that if somebody has heart failure, the heart is enlarged to the point that the electrical impulses are going to take a very, very long time to kind of get to the RV and to the LV. Okay, but if this is just initially when we're seeing these patients and if their EF continues to stay less than 35%, then because of all this, they're prone to a lot of VTs and VFibs. And that's why we put in defibrillators. Okay, the defibrillator has 2 leads or 1 lead. If it's just 1 lead, it goes to the RV. If it's 2 leads, it goes to the RA and the RV. Okay, and that's that. Over time, these patients' hearts from being this size become this size. Okay, imagine how long it'll take a current from the SA node to kind of go down all the way down to the RV and the LV together. And when the heart contracts, it doesn't contract like this. It contracts in a ringing motion. Okay, so the LV and the RV need to contract together. That's where the idea of CRT or bi-V pacing or whatever you want to call it came from. What happens is there are 2 leads. One goes to the RV and the other goes to the LV. And the impulses go together in such a way that they contract together so you can get maximum cardiac output out. So that's where these came from. And there's certain criteria that we need to know. The EF has to be a certain number, it has to be less than 35%, and they have to have a left bundle branch block. And this is more advanced heart failure. Even internal medicine doesn't do a lot of this, but it's more advanced heart failure. But normally they'll have an ICD and then they'll say, let's upgrade to a bi-V or let's upgrade to a CRT. But that's what it means. And that means that the heart is getting so enlarged and globular that basically an impulse cannot even go. And then, after all of this, despite that, if they keep coming into the hospital, if they keep having all of these problems, then they kind of go into stage D heart failure. And that's where you call, advanced heart failure for, let's say, mechanical circulatory devices. Maybe they need to be evaluated for cardiac transplant. And this is a good time for us to call palliative. I think we underutilize palliative services in heart failure, and it's very, very important. They actually studied a lot of patients who had palliative care come and see them in the first 3 days. And those patients did better over the years than patients who were not seen by palliative care, just because they understood their condition a little better. So just a few considerations in medical therapy. What do you guys think? Is a Lasix drip better than intermittent pushes? Oh, yes. Okay. Well, no, it's not. So they did a trial called the DOSE trial, okay, which said that whether you give patients a drip or whether you give patient pushes, it's the same. The reason we tend to use pushes is because let's say you want to give a patient, I don't know, a total of 80 IV BID. And if the blood pressure is 90/60, nobody's going to do that. So it's easier to give 10 IV every hour as opposed to just 80 IV at one go. But there's no real benefit to kind of using either or. Does everybody need a diuretic on discharge? No. So the answer is no. Not everybody needs a diuretic. Sometimes these patients have minimal lower extremity edema, and then these patients, if you put them on appropriate guideline-directed medical therapy, which is what we spoke about, your ACE inhibitors, your beta blockers, your mineralocorticoids, and the SGLT2 inhibitors, you don't need a diuretic on discharge. Is carvedilol better? This is a question that we get a lot. And I don't know what you guys thought. Is carvedilol better than metoprolol succinate? No. So, a landmark study came out and it was called the COMET trial. And they actually compared carvedilol, but they compared it with metoprolol tartrate. And in that, carvedilol was better. But we don't use tartrate. We use succinate. We use metoprolol XL, right? So if there's no head-to-head trial that compares the both, but honestly, metoprolol is a little better for these patients because it's once a day dosing. And these patients already have so many medications that carvedilol is a BID dosing, and it becomes hard for them to kind of keep track of all those medications. And then what medications does a patient need on discharge? So they need all their guideline-directed medical therapy with or without a diuretic based on what their volume status is at the time of discharge. Okay. And then outpatient follow-up for heart failure. I think this is where you guys can do a great job because, even when we're downgrading patients from the CCU or ICU down to the floors, it's important for us to impress upon our patients that they need to see a doctor within the next week. So actually they said patient contact within 7 days of discharge. And it could either be a televisit, it could be just a phone call from a nurse, or it could be like an in-person visit. But patients who had contact within the week from discharge did better than patients who didn't. Okay, and that's because you can reconcile the medications, you can go up on doses, you can change some of the medications. That's how it is. I just wanted to put this slide here to kind of show you guys the difference between Entresto and SGLT2 inhibitors. So this was the landmark trial for Entresto. It came out in 2014, and the Emperor Reduced trial came out in 2019. Okay, so the trials are 5 years apart, and they were both large studies. This trial had about like 8,000 patients, and that one had about like 6,000 patients. And we talk about, doing better for the patients, making sure that we take care of morbidity, mortality, but nobody talks about heart failure rehospitalizations, right? That problem became so bad in the early 2000s that heart failure was added to the Medicare as a 30-day readmission ding. Okay, so anybody who had heart failure and was discharged and then they get readmitted back, if they were readmitted in 30 days, that provider and that hospital does not get paid. So that is why heart failure hospitalizations are such a big thing. Heart failure rehospitalizations are such a big thing. So, all of these studies for heart failure medications, they're going to have a graph for like rehospitalizations. And you can see on the left, this is when Entresto was studied. If you can see hospitalizations for heart failure, the curve from enalapril, it starts dividing between 180 to 360 days, right? So it at least takes 6 months to 12 months before we can see an obvious difference in the rehospitalizations. But look at that for the SGLT2 inhibitors. Even like right from the start, the curve is different. And within 90 days, you can see a significant difference with these patients not being rehospitalized and readmitted. Okay, so that's why there's like a big paradigm change in the way we manage heart failure. What providers are trying to do now is, when patients come in, we diurese them and then we put them on a beta blocker and then we put them on an SGLT2 inhibitors, because these are the two things that prevent hospitalizations in the short term. And then when they go out, they see their primary care provider. That's when ACEs and ARBs should be started, because look at that, it takes between 6 to 12 months for us to even see an effect, right? So why don't we start something that will make them feeling better also? And it's like a positive reinforcement curve, right? Patients take those medications, they don't come in, they feel better, so then they're more inclined to keep taking those medications. So that's where the whole new change is coming from in heart failure therapy. And obviously diet plays a big role. We are what we eat, right? So the American Heart Association says less than 2,300 milligrams of sodium, but there's no studies to validate this, but they did study the DASH diet. And what did the DASH diet say? The DASH diet said that if patients follow the DASH diet, which is this on the right, which is like an appropriate balance, then these patients will not have as many hospitalizations as patients who do not follow the DASH diet. All right, just a few words. How are we doing on time? Okay. 33. Okay, just a few words on like heart failure with preserved EF. How we treat heart failure with reduced EF is very different from how we treat heart failure with preserved ejection fraction, right? That's your EF more than 50%. So for reduced, we're going to use all these medications. The same medications that we studied for reduced were studied in the preserved, and they found that there was barely any benefit. So for the longest, I think until Thomas and I were like interns, all we were doing for these patients is like control the blood pressure, control the diabetes, control, have them lose weight. And maybe mineralocorticoid receptor antagonists like aldactone can help, okay? And then in 2021, the landmark trial came out, and that was the same drug. It was SGLT2 inhibitors, and it's called the Emperor Preserved trial. And they actually reduced hospitalizations and they improved quality of life. So, now the first line for heart failure with preserved ejection fraction are going to be SGLT2 inhibitors, followed by your mineralocorticoid receptor antagonists. Of course, you should take care of all the other things. Risk modification is the most important thing: blood pressure, diabetes, weight loss. But if you're going to start them on a medication, it's going to be this one. And then just briefly touching on to cardiogenic, these are my last few slides. So, if we talk about cardiogenic shock, I put this slide here because there's also a staging and a class that we use and we put in our notes for cardiogenic shock. And that's called the SKY classification. And what the SKY classification does is like identify patients with heart failure who really need like higher level of care, be it ICU, CCU, tele floors, okay? So Your stage A is a at-risk patient. Their EF is probably really, really bad. Okay, their EF is maybe like, let's say 10 to 15%, but they're not hypotensive and tachycardic yet, and they're not hypoperfusing yet. Stage B is the beginning, and that's when you see the vitals change. That's when they start becoming a little hypotensive because the heart can't keep up with that cardiac output, and you start seeing them become a little tachycardic. This is when normally the resident teams on the floors call CCU. Okay, and then when we go and touch their legs, they're like stone cold, right? So when you order lactic acids on these patients, they're like in the 6s, 7s, 8s because they're just not perfusing. That's when we come into stage C. And remember, stage C, classic, stage C, CCU. Okay, any classic cardiogenic shock should be in the CCU. They're hypotensive, they're tachycardic, and they're hypoperfusing. These patients need to be watched every hour, and these patients probably even need inotropes and or mechanical circulatory devices. Okay. Stage D is deteriorating. This is like, they're hypotensive, tachycardic, hypoperfusing, they're on milrinone. We're at 0.5, not doing any better. We're adding dobutamine, and we're calling Dr. Montgomery to come evaluate for maybe WADs or, balloon pumps or something else. Okay. And stage E is extremist. This is like refractory shock. They're on multiple devices. They're on multiple inotropes. Despite that, they're not doing better. And at this point, we start having either DNR discussions or further escalation with like VA ECMOs for these patients, if they are heart transplant patients. Okay. So, but this is where, so for most of you guys will see these patients in the stage CDE stage because they will be in the CCU, and now even more so. I think once we move to C6, when we have more beds, like even patients who need like a higher level of care with heart failure will come to you guys. And then the last slide is just a little bit about like inotropic support. So I know our culture here is to use milrinone and dobutamine, but all of these have been validated and studied. So, if you're using adrenergics, you can use dopamine. I know we only use it for bradycardia here, but you can use it for multiple things. You can also use it for cardiogenic shock. And then dobutamine. If you're using a phosphodiesterase inhibitor, it is milrinone. And the idea behind it is what? Milrinone is going to augment your cardiac output, but it also has a relaxation effect on the smooth muscles. So it's going to reduce the afterload so that the heart can pump more effectively against a lower resistance. And that's where milrinone comes into play. And then you can still use your pressors, whether it's epi and levo. The ones that I highlighted are the ones that we use here. And you can see they're kind of the same, except for milrinone, like I said, has an effect on the smooth muscles. So a lot of these patients with pulmonary hypertension would also benefit from milrinone because you're going to relax the pulmonary vasculature as well. And, just to kind of let you guys know, there's no benefit of one inotrope over the other. So whether you start somebody on milrinone or dobutamine, it doesn't matter as long as they are on a inotrope. Okay. And the role of inotrope is, there's two roles. One is palliative therapy. And that's why we have a lot of our patients with PICC lines on milrinone. And that's more like a palliation measure, right? Because we want their heart to keep beating. We don't want them to keep coming into the hospital multiple times. The other role is that as like a bridge to some therapy, either to a mechanical circulatory device or to a VA ECMO. But they shouldn't be on inotropes for so long because of course it's going to affect the vascular bed. Okay? I think those were like my 20-25 minutes on heart failure. I think the main takeaway that I want you guys to take away from this is when you guys read our notes, like, the staging and everything that we do, that's why we use certain medications over the other. And I know you guys read our notes and I know you ask questions. And that's why if we spoke about this and we kind of did this over and over, it might be easier for you guys also to kind of understand this and help with a lot of patient care stuff. The other thing is metoprolol over carvedilol in asthmatics and COPD patients. And the last thing is always an SGLT2 at discharge. Yay. Thank you. All right. And these are my references, but yeah. Did you guys have any questions? No? No? Yay. Okay. All right. Thank you.
Thank you so much, Dr. Shreya. We're really off like a good start, right? With the heart failure, like very good update and, a lot of knowledge. We got this, early start. Now our second topic would be mechanical circulatory support devices. So we thought of, instead of like giving you, like the information, just like balloon pumps and Impella, we thought of making it like a debate, like which one is better, right? So just a little light discussion about the devices. So Olivia is actually handing out like papers. So you decide which one is better. Is it balloon pump or is it Impella? All right. So Olivia has been with us for like 4 years now. Yeah, 4 years now. And she is like very active with our C8 education committee and used to be unit-based council also. She's also and she just had her PAS level 3 awarded 2 days or 3 days ago. So congratulations, Olivia. And next debater is I keep saying Brielle Sutter, but it's Brielle Dwyer now. Brielle has been with us for like 7 or 6 years. She is also with the C8 Education Committee. When we started this mini symposium, Brielle was actually with me. So it's just like one of the pioneers of the mini critical care symposium. I guess we're good. Okay, all right. Oh, thank you so much again for attending today. Actually, online we have like 50 signed in, online. So thank you.
Okay, thank you all for coming. Yeah, I want to say there's like almost 25 of us here and 53 of us online. This is like almost our biggest symposium yet, so woo! So again, thank you all for coming for a great day of learning. We are starting the great debate. What is better, a balloon pump or an Impella? And I hope at the end, we'll kind of come to a conclusion about which is actually better. You guys ready?
Impella. Let's get ready to rumble.
Okay, so like Dr. Shreya, I really wish that we had financial disclosures, but we don't. But if someone wants to sponsor us, you have my email. So our objectives is we'll be able to identify at least 3 differences of each device. And our heart failure program is growing every day, so it's really important that we have these basics down. So before I go on an overview, everyone hold up their signs. Who do you think is better right now? Pick your sign. Impella. I see Impella. I see a balloon pump. I see balloon pump. I see a couple Impellas. Fantastic. So an overview of the balloon pump, just to kind of give you an idea of where these devices came from. The intra-aortic balloon pump was first used in 1968 by Dr. Kantowitz. Does anyone know what LT is famous for? Dr. Kantowitz. What else is he famous for? Does anyone know? We do it here many times a year. Yeah, who said heart transplant? Is that you too? It was Marisol? Okay, Marisol, you get a badge at the end. Ooh. So he wasn't the first person to do a heart transplant, but he was the first person to do it here in the US. Oh. He was the first person to do it here in the US. It was a pediatric patient, and the patient lived for, I think, only a couple hours, but the patient was, very sick to begin with. So he's actually the one who kind of pioneered this idea, despite the fact that the idea was theorized a decade previously. They just didn't have the technology to actually perform it. So if you see in this picture A, that's what it first looked like. Back in 1968, it was as big as a refrigerator, so it's much different to the device that we see now. Balloon pumps use counterpulsation technology with a balloon that inflates and deflates to cause a different pressure gradient to offload that ventricle. And like I said, it's been 50 years of a device. It's considered a safe and very simple with low risk of complications. I know almost everyone here knows how to take care of a balloon pump. It's like old, reliable, I always say it is, versus its newer cousin. So as you can see here on like the slide, the balloon pump sits in the aorta, it deflates with that counterpulsation technology. It happens with synchrony of the heartbeat, so it works in together with the heart. And it's triggered by either EKG or fiber optic readings. It inflates during diastole, and it creates that pressure at the aortic root of about 70%. And then as the heart starts to have that isovolume contraction, like right before it really contracts, right before the aortic valve opens, the balloon will deflate. So timing is imperative. So as the heart contracts and the balloon deflates, it creates a pressure gradient. So it actually almost like pulls the blood out of that ventricle. So this helps decrease afterload because it almost creates like a vacuum. So that pressure is very low. And also just kind of helps pull that ventricle, as well as when the balloon inflates during diastole, you know, coronary arteries get the most blood supply during diastole. So you're hyper like oxygenating those coronary arteries, which is really important with your sick myocardium. So here's just like waveforms. Oh, look at that. So here's your waveforms on your balloon pump. This would be almost like a 2-to-1 augmentation. So as you see here is your unassisted aortic and diastolic pressure. And as the balloon inflates, the pressure actually drops much lower. So like I said, it really helps that afterload, decrease that afterload to help the heart pump more effectively. And as you hear, it's like another 2-to-1. So you can see the different pressure gradients between your diastolic augmentation and your assisted systole and your unassisted systole. So here's just another picture of kind of like what it looks like. It can be inserted via the femoral artery or the subclavian. We love the subclavian one because then our patients can ambulate. They're not bedridden, they're not uncomfortable, which is really nice. And of course, we've all kind of seen this tracing. The top is the EKG tracing. The middle is your balloon augmentation pressures. And the bottom is actually what the balloon is doing, you know, inflating, deflating with those peaks and valleys. Just another summary. So the systole is the deflation. It decreases the afterload. It decreases the amount of oxygen that myocardium needs because, like I said, it creates that vacuum. So the heart doesn't need to push so much blood out and actually helps pull some of that blood out to increase your ejection fraction. And that inflation during diastole perfuses those coronary arteries, especially that are either occluded or just got stented, or they have that ischemic injury from like a myocardial infarction. The most common uses of a balloon pump is refractory angina. So like, you know, occluded stents or partially occluded stents, cardiogenic shock. Sometimes the heart needs a little help after surgery, after it's been damaged. So cardiac failure after surgery, if it just needs that little extra support. Ventricular support during and after high-risk PCI. So I know sometimes the cath lab will implant these devices during stenting and then either leave them in if that's what the patient needs or take them out if the pressures improve. As a bridge to transplant, we have a lot of heart failure patients, especially on C8, that are just kind of waiting for their heart. They're too sick to go home. So having a balloon pump really helps optimize their recovery because they can stay mobile. They feel a little bit better, so they're able to keep their like standard of care high. They can feel better, they can walk, they don't decompensate as fast if they have a balloon pump. We can use it in cardiogenic shock and also acute decompensated heart failure that hasn't progressed to shock yet.
All right, so now we have the Impella. Here's a picture of the Impella catheter in the left ventricle supporting the left side of the heart. In this next slide here, we have the whole Impella setup. So you have the catheter, which is in the heart. It is connected to the cable that attaches to the controller and the purge fluid that is flowing to the sidearm to get to the catheter to prevent clotting. So we have the types of Impellas. The Impella devices are catheter-based devices that provide hemodynamic support while allowing the heart to rest. The types of Impella catheters are the Impella CP, the Impella 5.5, which both support the left side of the heart, and the Impella RP, which supports the right side of the heart. The Impella CP and 5.5 can be inserted percutaneously through the femoral or axillary artery or surgically through the axillary artery or aorta. And the Impella RP can be inserted percutaneously through the femoral vein. Here we have the Impella CP with Smart Assist. It's a heart pump that's approved for use in high-risk percutaneous coronary intervention and cardiogenic shock. Here, if you look at the picture, we have the blood inlet area where the blood is drawn into the cannula, the outlet area where the blood exits the cannula into the aorta, and the optical sensor, which assists in positioning, managing, and weaning the Impella heart pump. When the Impella device is properly positioned, it pulls from the blood from the left ventricle through the aortic valve and into the root of the ascending aorta. This flow reduces ventricular and diastolic volume and pressure and increases the mean aortic pressure and flow. And here's a slide with the p-values. So with the p-values, you can like adjust, it's called performance level, and then you can adjust the flow, which also, you get a higher cardiac output. The more like revolutions per minute, the higher the flow you would get. With the CP, the highest flow you can get is like 3.5, 3.7. Right, here we have the Impella 5.5 with Smart Assist. It's a minimally invasive surgical heart pump that provides full cardiac support with maximum unloading, allowing the heart to rest and recover. It unloads the left ventricle, reduces ventricular work, and provides the circulatory support necessary to allow recovery and early assessment of residual myocardial function. Similar to the CP, the Impella 5.5 has an inlet, outlet, and optical sensor. The difference between the two is the 5.5 doesn't have that pigtail at the end of the catheter, keeping it in place. It moves blood in the same way as well. So it pulls the blood from the ventricle through the aortic valve and into the root of the ascending aorta. And since the blood is moving through in the same direction as a CP, the flow still reduces ventricular and diastolic volume and pressure and increases the mean aortic pressure and flow. Next slide. All right, and here's just a closer image of the 5.5 in the left ventricle. If you see, it's placed with the inlet past the aortic valve and the outlet in the ascending aorta so that the blood will move from the left ventricle into the aorta. And here's another image of the 5.5 with the catheter and the cable. So the cannula sits in the heart. The blue suture hub is attached at the suture at the insertion site on the outside of the body. The sterile sleeve lock locks the catheter from moving. When it's unlocked, the physician or advanced provider can adjust the placement of the Impella at the bedside and within the sterile sleeve. All right, next type of catheter is the Impella RP with Smart Assist. It's a single vascular access pump designed for right heart support. The Impella RP with Smart Assist is inserted percutaneously through the femoral vein and into the pulmonary artery, with the inlet sitting in the IVC and the outlet in the PA. It enables biventricular support when the left side is supported with the left-sided Impella. It still has an inlet where the blood is drawn into the cannula, and that's sitting in the inferior vena cava at or below the level of the diaphragm. Your outlet area is where the blood exits the cannula. And then the dual sensor, it has a dual sensor where, it's comprised of the differential pressure sensor and optical pressure sensor. So these assist in positioning, managing, and weaning of the Impella heart pump. And when it's properly positioned, it pumps blood from the inferior vena cava into the pulmonary artery. This flow reduces ventricular workload, decreases central venous pressure, and increases overall blood flow into the left heart. All right, and here's just an image of it inside the heart. All right, another part of the Impella catheter is or Impella device is the automated Impella controller. This is what your Impella catheter is attached to by the cable. It provides insight into the catheter function at a glance. It's an interface for monitoring and controlling the Impella heart pumps. It provides real-time operating data. It also delivers purge fluid to the Impella devices. The purge fluid is used to prevent clotting in the cannula, and it also provides backup power. So when it's fully charged, it can operate on its battery for at least 60 minutes. Here's an image of the automated Impella controller for the Impella CP in 5.5. The red line here is the aortic waveform. The white line is the left ventricle pressure, and the green is your motor current. And on the bottom of the screen there, it shows your Impella flow, current purge flow and purge pressure, cardiac output, and cardiac power output. And then with the Smart Assist, it calculates the cardiac output and cardiac power output to aid in measuring end organ perfusion. This is an image of the controller screen for the Impella RP. So here it displays the pulmonary artery waveform shown as the yellow line, the central venous placement signal, which is shown in blue, and below it is the motor current waveform in green. It also shows a calculated PAPI score. It also shows on the bottom of the screen, as well as the as seen with the CP in 5.5, shows your Impella flow and also the purge system. All right, so I've been saying Smart Assist like after every Impella, so they have something called Smart Assist. It's a cloud-based program for the Impella. It simplifies the setup of the Impella device. It allows for remote monitoring for better patient outcomes. So if advanced practitioners at home and they want to check on their patient and see how they're doing, they're able to log in and see, you know, the numbers and what's going on with the device at the time. It's also good for if you're having issues with your pump as well. So the Impella rep can log in, look and see what's happening. If you're having like suction alarms, they can help you troubleshoot. It also has new sensor technology on the cannula. So all those dual sensors, optical sensors, they allow for better repositioning and real-time advanced and intelligent metrics. And these metrics can help us show weaning trends of left ventricular end diastolic pressure and MAP, which assist in hemodynamic assessment and successful weaning. You'll have better and faster resolution of suction alarms and earlier identification of right heart failure. And as I said before, it also helps display and calculate the cardiac power output.
Okay, here's a checkpoint. Hold up your signs. What are we feeling now that you have an overview of both devices? Okay, see Impella and see Impella. Thank you, Grace. We have a balloon pump lover over here.
I know we get a lot of Impella.
Yes, Jody, balloon pumps. Woo. Yes, Maria, balloon pumps. Okay, so now we're going to talk about the advantages and disadvantages of kind of both. So first, the advantages of the balloon pump, like I said, old, reliable, 50 years of research and data with, more usage, more improvement. We don't need, 5 different devices doing different things. We just have one good balloon pump we all know how to use. Over 50,000 balloon pumps are inserted annually. So it's something that hospitals are comfortable using. It's nurses are comfortable taking care of these patients. And it's really a more well-known, well-utilized device with like different complications. 50,000 is a lot. I couldn't find a direct number of how many Impellas are inserted, but only 1,000 hospitals in the US implant Impellas, which you think is 1,000 is a lot, but in reality, there's only 1,000 hospitals in just New England. So there's a whole other country of hospitals that, don't necessarily use Impellas. It's a really small catheter. It's only 7 to 8 French cannula, and it can be inserted at the bedside. Or if they go to cath lab, it can be inserted axillary, in which the patient can then ambulate. It's a preferred method in multi-vessel coronary artery disease due to that increased coronary artery perfusion. And due to that, it also decreases afterload because it gives that myocardium extra oxygenation. And like I said, using that vacuum technology with that counter pulsation pump, it kind of pulls that blood off the ventricle. It works within the cardiac cycle rather than independent of it. So, we really have to have, I know you have to have a native heart function, but it kind of just helps that heart recover because it works with it instead of just independently. It decreases the workload, which may allow for a lower dose of inotropes. Inotropes are great, we use them, but they don't come without risk. They can cause tachyarrhythmias, myocardial ischemia, can cause hypotension and tissue necrosis in those fragile capillary beds, like the periphery and for example, like the kidneys. It benefits patients with severe LV failure. I'll go into it a little bit later, why the Impella is not so good with severe LV failure. There are new studies going on that we can actually use balloon pumps without anticoagulation. The studies are not yet published, but they're in the works right now, and they're showing promising data. I just don't have the numbers yet. That if a balloon pump is on 1-to-1, they don't necessarily need anticoagulation. It's different when we start to wean them, but for now, like I said, the studies are there. It's also a low-cost option, and a balloon pump only costs between $800 to $1,200 for the device and the insertion, which sounds like a lot, but you'd be surprised how expensive other devices are.
All right, so here we have the advantages of Impella, just kind of going through like how it works. So the blood's going to move continuously from the left ventricle to the ascending aorta, as I said. So this directly unloads the blood from the left ventricle, decreasing end diastolic pressure and volume, subsequently increasing the aortic pressure and the flow. You will have decreased oxygen demand and increased oxygen supply, and thus increased systemic hemodynamic support. Cardiac power output is measured in watts, and it's formulated using the cardiac output and mean aortic pressure. A cardiac power output less than 0.6 watts is indicative of a hemodynamic compromise and associated with increased mortality. All right, so some advantages of Impella. These first few advantages I explained in the previous slide. So when we go into the efficacy of the Impella is independent of rhythm, whereas with the balloon pump, the balloon is trying to inflate and deflate to each heartbeat. So if you're in tachycardia, it's going to be difficult, or AFib. There are different ways to insert the Impella, either percutaneously or surgical. It's a small cannula size as compared to VA ECMO.
Mine's smaller.
You can do bedside position adjustment with that sterile sleeve lock.
So you can do that with a balloon pump too.
The automated Impella controller is easy to read and use, and it has a smart assist which displays and calculates various hemodynamic metrics, which balloon pump, I believe they don't have those.
Not yet.
There's a reduction of mortality. It's cost effective in the long run, as with, with reduced length of stay and reduced readmissions, which I will speak more of in the next slides.
So the device itself is not cost effective, but maybe its after effects will be.
Yeah, the afterwards. Maybe not upfront, but the after costs. All right. So here we have a it's showing Impella is associated with reduced mortality and costs. Studies show the use of the Impella is particularly cost effective, with a 29 to 47% reduction in adverse events at 90 days. So that's your death, stroke, MI, and or repeated revascularization. There's also a 58% reduction in 30-day mortality for patients with CAD. And also there's a 44% lower in hospital mortality for patients with higher comorbidities versus the balloon pump.
I just want to point out though this graph looks like that Impella is better, I also just want you to take a look at the sample size. Impella only has about 4,500 in their sample size versus balloon pumps has almost 17,000. So that's almost quadruple the data. So this uneven sample size can affect the statistical power of the study, and it introduces kind of bias. And it makes the evidence less precise. So yeah, the dark blue is the PVAT or the Impella as we're using it, and then the light blue is the Impella. So I just want to show you that 17,000 sample study versus 4,500. So these graphs look a little biased.
Listen, we're the new kid on the block. We just had FDA approval in 2015, so we're getting up there. I mean, you've had what?
50
40
years,
60 years, 60 years to come up with the data. All right, and here we have, what was it? The cost effectiveness of it. Just showing reduced length of stay for patients with the Impella, and also fewer readmissions as well.
Okay, this graph is a little bit better because the sample sizes both are around 200. But this one, I'm a little suspicious. Okay, so we're gonna talk about the disadvantages of both.
All right, so here we both have our disadvantages are limb ischemia, thrombocytopenia, bleeding, infection, at the insertion sites, immobilization from where the device is placed, probably in the femoral artery, which would cause the patients to have to be almost supine in bed, and device malfunction.
As in most things we do, we really have to weigh like the risk versus the benefits, because these devices are great, but they're not without fault.
All right, so some disadvantages of the balloon pump. You can have dissection of your aortoiliac access. That's if the balloon pump is placed femorally. You can also have intravascular thrombus. Complications are higher for women, patients with PVD and diabetes. And then obviously if a patient has all of these things, and they're at the highest risk for complications. Also, the longer duration of the balloon pump support, you have increased risk for complications such as septic and thrombotic emboli. And you can also have end up developing claudication or nerve paresis if you're having vascular issues as well. The poor quality EKG and cardiac arrhythmias may lead to inaccurately timed balloon pumping.
Poor quality.
Not only negating the hemodynamic benefits, but also increasing LV workload as a myocardium contracts against the inflated balloon. Balloon inflation in the presence of aortic regurg increases left ventricular end diastolic volume and pressure, inducing further ischemia. It's like, you know, the whole thing we're trying to prevent. Balloon rupture, it may cause air embolism that could lead to neurological injury. As we had said, the proper device positioning is important. You could close off blood flow to any lower limb, or any visceral perfusion may be poor. And also the balloon pump doesn't support the RV.
So it actually indirectly supports the RV by perfusing those coronaries. And the right coronary actually doesn't get as much blood flow as the left due to that pressure gradient. The left kind of sucks it all up, especially because it's a bigger part of the myocardium. So although it doesn't directly offload the RV, it does, you know, help it by giving it the oxygen that it needs to pump.
Listen, we have a whole device for it though. All right, and then in this landmark study, the intra-aortic balloon pump shock 2 trial, it ended up showing that the intra-aortic balloon pump has no effect on all-cause mortality at a 6-year long-term follow-up. Mortality is still very high with cardiogenic despite contemporary treatment with revascularization therapy.
Okay, now I get to fight for my balloon pump. Here are the disadvantages of the
Fight for your
Impella.
life.
Okay, although the Impella might be designed to provide a more powerful and sustained direct circulatory support, patients with severe LV dysfunction actually have an increased afterload caused by the axial flow of the mechanism of action of this Impella. So the direct blood flow from the ventricle to the aortic causes a high aortic pressure, which actually can increase afterload on those patients with severe weakened LVs. Due to its placement, and it can also cause mechanical trauma to the aortic valve. You know, if these patients are already having issues, a leaky aortic valve is not something that you want when that device is removed. And like I said, Impella's only got, you know, the 2.5 was only approved in 2008, and the 5 was
2015.
approved in 2015. So I don't know if it, you know, works yet.
We're new, advanced. The future.
And although Brielle mentioned that it might cause readmissions or decreased lengths of stay, I just want to put it out there that the Impella can cost anywhere between $10,000 to $40,000. The 2.5, which we don't really use anymore, is $22,000. So that's very expensive. The balloon pump, like I said, it's only like $800 to $1,200. You know, it's a cheaper
Listen, we're going to pay
alternative.
for it in the afterwards, though. When patients are readmitted, when they're coming in back with complications.
Also, the FDA only approved the Impella for 6 hours. So anything after 6 hours is, you know, off-label use, just saying. Like I said, there's a limited availability of Impellas or facilities implanting Impellas, and you need that specialized training. It needs anticoagulation. That purge fluid always comes heparinized as well as systemic heparin. There's a higher risk of vascular injury. Just like I said, you need a bigger sheath, or it has to be surgically implanted, which can cause trauma to that spot. And there's a higher a risk of stroke. In multiple studies, the Impella is around 5 to 7% incidence of stroke, where balloon pumps are only around 1 to 2. Okay, checkpoint. Where are we feeling? Okay.
Ooh.
Here, we'll let
All right,
everybody.
yeah, let's see. I
All
see a
right.
lot more balloon pumps
I see
right
a lot
now.
more
I see a
balloon
lot more balloon
pumps,
pumps,
yes.
but Impella is still hanging strong.
Okay, are you guys, are you guys ready? There's actually inconclusive results. So there's a landmark PROTECT 2 trial, which did not show statistically significant difference in 30-day all-cause mortality with either balloon pumps or Impellas. They're currently doing the PROTECT 4 trial, and that's ongoing. So we'll kind of see, where it, projects us into the future. And then there's an article by Feely et al. That is the largest historical cohort that investigates the hemodynamic benefits of Impella versus balloon pump in patients with myocardial infarction complicated by cardiogenic shock. Despite the fact all we do, these patients are so sick. So like there's going to be a 40 to 75% chance of mortality no matter what we do. But this study was 700 patients from 48 hospitals from 9 different countries that showed, again, there's no difference between the 30-day all-cause mortality between the two groups. And like I said, each device has their benefits and their downfalls within this. So the Impella had a higher risk of vascular complications such as bleeding, but the balloon pump had a higher risk of limb ischemia. So, you pick your battles. As these graphs kind of show, the black is the balloon pump and the blue is the Impella. Although the Impella might start off better right out of the gate with decreasing serum lactate, improving ejection fractions and such, if you see, they both end up at the same. So, balloon pump, slow and steady wins the race. Impella, they might start off faster in the gate, but, they cross the finish line at the same time.
All right, so there's multiple factors to be considered when determining the mechanical circulatory device you're looking for, such as the device itself, hemodynamic impact, disease severity, situation urgency, available access sites, coexisting mechanical supports, structural abnormalities, and institutional factors. In mild hemodynamic instability or emergent situations, balloon pump is often considered in view of its low cost, ease of insertion, and operator familiarity. Concomitant pharmacological support is often necessary and may be adequate for temporary support, and centers with experience may prefer the similarly low profile Impella 2.5 CP, which is inserted just as quickly and provides superior hemodynamic support compared to the balloon pump. The anticipated duration of support, anatomical variations, and exit strategy are also factors that need to be considered.
And the winner is, can we get a drum roll? You guys ready? And hold up your signs. It's you guys! Woo! Yay. These devices have their benefits and their cons, but they're just pieces of metal without the hardworking nurses at the bedside really caring for these patients, monitoring for those complications, and managing those patients so they can get home. So, there's no device without you guys. So, woo! Does anyone have any questions? Does anyone, sway? They thought balloon pump was better, now they're on Impella? No?
No.
Stubborn groups of folks.
Yeah, they know. All right, thank you.
Thank you all.
Awesome.
Okay.
Let me just make sure Dr. Gidea is all set up.
Oh yeah, you do that because I.
Dr. Gidea, are you with us?
Hello, yes.
Okay,
Everybody's hearing me? Everybody's seeing me?
so I'm going to stop our share momentarily. If you'd like to try and share your screen, Dr. Gidea.
Okay, I'll try to do this. Can you see it?
Yeah, and you should be able to see our audience here, Dr. Gidea.
All right, okay. So let me know when it's my time to start.
Dr. Gidea, it's Leon. I'm going to introduce you to the team. So I have the pleasure of introducing Dr. Gidea to you guys. She is the medical director of our heart transplant, mechanical circulatory support, and advanced heart failure. And I have to say, I've not met a physician who's more committed to increasing the knowledge and supporting the education of our nursing staff. When I asked Dr. Gidea to speak, I got 3 words out and her answer was already yes. And in the edit, she said, when is this conference? And I told her a date. She goes, well, I'll be away on vacation. And again, she said, I absolutely do it. So, I think, if I'm not mistaken, you're in Romania right now, right, Dr. Gidea?
Yeah, I'm actually in France. I came
France.
last night from Romania to France, but as you said, I'm committed.
Yes. So again, I want to give a big shout out and thank you to Dr. Gidea. on her vacation presenting to us from France. So I think that shows how much she cares about the knowledge and sharing with you guys. All right, without further ado, go ahead, Dr. Gidea.
Thank you. Thank you for the introduction, and thank you for giving me the opportunity to present at critical care conference about cardiogenic shock. And I do not have any relationship to disclose related to this talk. And these are the objective of the talk: to clarify the new cardiogenic shock definition and classification, to go over the cardiology shock etiology and phenotype, to understand the role of temporary mechanical circulatory support in cardiogenic shock, and then to talk about New York Beth Israel Medical Center cardiogenic shock protocol. So how we define cardiogenic shock? Cardiogenic shock is defined as a state of tissue hypoperfusion. This is a very important word, and end organ dysfunction, and is due to a primary cardiac disorder that leads to a low cardiac output and cardiac index that can present in different stages of the Society for Cardiovascular Angiography and Intervention, or SCI, because the new classification of cardiogenic shock has to deal with the SCI stages. And as a consequence, cardiogenic shock is a multifactorial, complex hemometabolic and multisystem syndrome, which is associated, as we probably learned so far, with high morbidity and mortality. So as you remember from the heart failure 4 quadrants, there are 4 quadrants of the cardiogenic shock also. And the classic cardiogenic shock is when the patient is wet and hypoperfused, cold, which means they are high feeling pressure, patient is volume overloaded, with increased systemic vascular resistance, hypotensive, hypoperfused, cold, clammy, mostly the extremities, and organ dysfunction, decreased urine output, altered mental status, and of course, as we describe below, the decreased cardiac index. We'll have also the type of cardiac shock, which is called euvolemic, which the capillary wedge pressure is normal. The patient does not present with volume overload, but it is increased systemic vascular resistance and again decreased cardiac index. We sometimes have cardiogenic shock after acute myocardial infarction, and this most of the time it's complicated by the systemic inflammatory response syndrome that leads to a vasodilatatory state, or there are many times when the patients have cardiogenic shock due to acute decompensated heart failure at home with a PICC line, and they come also in septic shock. This kind of mixed shock, it's a warm and wet quadrant, and it's characterized by increased feeling pressure, decreased cardiac index, and decreased systemic vascular resistance. So what characterizes actually the cardiogenic shock is decreased cardiac index. This is the denominator. But when we have vasodilatory shock, like in allergic shock or in patients with true septic shock, then the cardiac index is increased because you are going to have profound vasodilation and your capillary wedge pressure is going to be decreased also. So this is the revised classification of the cardiogenic shock in 2022. This kind of pyramid was proposed by the SCI Association with David Barron as the first author in 2019. And what was changed from 2019 to 2022 from the first iteration? What it changed were like validation clinical trials, particularly related to morbidity and mortality. And as a consequence, a new classification was to be done. And the first thing major that was changed was the modifier. In the 2019 classification, the cardiac arrest was considered any cardiac arrest that needs defibrillation. But then we understood that cardiac arrest means more than defibrillation, means concern for anoxic brain injury, because the therapy is going to be different if the patient is going to have anoxic brain injury. So the fourth modifier was the cardiac arrest with concern for anoxic brain injury. So I'm going to go through each stages. Stage A, it's at risk. It's a patient who is hemodynamically stable, who who does not have any signs or symptoms of cardiogenic shock, but it's at risk for its development. Not all acute myocardial infarction are presented with cardiogenic shock, but they can present in a stable hemodynamically state, but in time might decompensate and might become patient with cardiogenic shock. Therefore, it's at risk. There is no hypoperfusion, the normal lactate. There is no hypotension. The patient is normotensive with systolic blood pressure more than 100, and the cardiac index is more than 2.2 with filling pressures and high SVO2 or pulmonary artery saturation. Stage B is the beginning. The patient is not hypoperfused. Again, I talked to you at the definitions that it's signs of hypoperfusion of the classic cardiac shock, but the patient is tachycardic and is hypotensive and is compensating for lack of hypoperfusion through tachycardia. Usually there is a warm patient and well perfused because the lactate is normal, but there is hypotension and there is tachycardia. And there is minimal and organ dysfunction, like minimal increase in creatinine and mild elevation of the brain natriuretic peptide. As going from stage B to stage C, this is the classic cardiogenic shock. The patient is hypoperfused, it's hypotension. The patient has volume overload, has a high lactate level, has end organ dysfunction, high creatinine, increased liver function test, higher level of BNP, and has low cardiac index and high wedge. I want to draw attention to you that the morbidity and mortality of patients who have hypoperfusion with or without hypotension, it's much higher than the stage B when the patient is hypotensive but not hypoperfused. So again, hypoperfusion with high lactate levels that I'm gonna emphasize later portend a higher risk for mortality and morbidity in cardiogenic shock. This is stage D, deteriorating. A patient is in stage C, stays sometimes in stage C, and then despite medical measures or temporary support, it's not doing better, it's doing worse. The lactate is much more than 2. The kidney function continues to deteriorate. You have raising BNP, and you have to escalate. From a balloon pump, you have to go to Impella, or you have to go to ECMO. And stage E is the extremis. This is the situations that patients come in cardiac arrest, and we have to place an ECMO while we are doing the CPR. This is the eCPR. This is profound hypotension despite maximal hemodynamic support. You have extremely larger signs of hypoperfusion, that lactate level more than 8. You have severe acidosis with pH less than 7.2 and the base deficit more than 10. So what did we understand from 2019 to 2022? That all these stages of cardiogenic shock are a dynamic process. A patient can come in stage A in 24 hours or 48 hours, can reach stage E despite proper medical therapy, or a patient can present in stage D or C and by proper medical therapy can go to the recovery pathway. So this is a dynamic process. A patient might go from one stage to another. So what is the etiology of cardiogenic shock? As probably was mentioned before by other speakers, cardiogenic shock due to acute myocardial infarction represent 80% of the case of cardiogenic shock. But as I said prior, only 5 to 10% of patients presented with acute myocardial infarction develop cardiogenic shock. Another entity that it's trying more and more to be recognized and has another phenotype and pathophysiology than cardiogenic shock due to acute myocardial infarction is cardiogenic shock due to acute decompensated heart failure, previously named cardiogenic shock due to non-acute myocardial infarction. And this represents less than 20% of all cases of cardiogenic shock. But 58% of these cases are due to acute and chronic heart failure, with 10% each myocarditis and 10% stress cardiomyopathy. The majority of patients who are present cardiogenic shock due to acute decompensated heart failure who are not acute on chronic heart failure are due to valvular or mechanical dysfunction. Particularly patients who come with acute myocardial infarction have complications, mechanical complications, like a ventricular septal defect or free wall rupture. 4% of cardiogenic shock is due to post-cardiotomy. These are patients who are going to any cardiac surgery, and there is difficulty to wean them from bypass. And then obstructive cardiogenic shock due to pulmonary embolism, pericardial tamponade, or progressive pericardial constriction. So we talk about etiology, let's talk about phenotypes. And I want to emphasize that we know about the cardiogenic shock phenotypes by having a pulmonary artery catheter in. So it's a mandatory policy, any patients who present with cardiogenic shock to have continuous hemodynamic monitoring with the pulmonary artery catheter. Very rare, 3 to 5%, is the right ventricular dominant cardiogenic shock. And you can imagine that this is probably most likely due to acute myocardial infarction. When the right coronary artery is obstructed, we have RV infarct, or due to pulmonary embolisms, or severe pulmonary hypertension. And what are the hemodynamic data? CVP or right atrial pressure is more than 15, wedge is low. But cardiac power output, which is a very important marker of a prognostic in cardiac shock, is less than 0.6. And what is this cardiac power output? It encompasses the mean arterial pressure or afterload and the forward flow, the cardiac output. So it gives us practical information about all the cardiovascular system. And what is PAPI? PAPI is the pulmonary artery pulsatility index, and give us information about the preload of the right ventricle, CVP, and afterload of the right ventricle, the difference between the systolic pulmonary artery pressure and diastolic pulmonary artery pressure. So by logistic regression analysis, it was shown that a poorer prognostic for patients in shock are when cardiac power output is less than 0.6 watts and PAPI is less than 1. When you have a cardiogenic shock due to left ventricular dominance, you have low CVP, you have high filling pressure, high pulmonary capillary wedge pressure, you have low cardiac power output and high PAPI. And you do have biventricular cardiogenic shock, most likely in the situation of myocarditis, postpartum cardiomyopathies, acute decompensated heart failure from genetic cardiomyopathy. Then you are going to have a wedge more than 15, CVP more than 15, signs of very low cardiac power output and decreased PAPI. So again, regardless what is the phenotype of cardiogenic shock, your cardiac power output is going to be low. Mean arterial pressure, cardiac output are going to be low. So this is the pathophysiology of cardiogenic shock. As I described, any primary cardiac insult leading to myocardial dysfunction will lead to decreased cardiac output. You're going to have neurohormonal activation, catecholamine release, renin-angiotensin aldosterone axis activation, vasoconstriction, more decreased cardiac output by increasing afterload, signs of volume overload by left ventricular dysfunction, and dilation, decreased organ perfusion, and then ischemia and inflammation. And the inflammation, the systemic inflammatory response syndromes that I mentioned before, that also it's an independent risk factor of mortality in cardiogenic shock. So what are the prognostics of cardiogenic shock? So I mentioned before hypoperfusion, and we measure hypoperfusion by measuring lactate levels and cardiac power output. And remember the formula. And it was shown that there are severe hypoperfusion, lactate level more than 4, and decreased cardiac power output less than 0.6. There is only 31% survival at 12 to 24 hours. Contrast this with 95% survival when you have no hypotension, normal cardiac power output, and you don't have hypoperfusion with lactate less than 4. So what we have to do to increase the survival in patient with cardiogenic shock. As you see in this table, over 30 years, different studies, and all these studies dealt with cardiogenic shock due to acute myocardial infarction, regardless what kind of definition they propose or what kind of therapy they've done, the survival was only 50%. The landmark trial, was conducted by Judy Hackman. This is the first shock trial, acute myocardial infarction, cardiogenic shock, revascularizations, improved survival, but the overall survival at discharge was only 50%. It was in 2018 that Ionova Center implemented a cardiogenic shock team. And this is the only trial in all these trials that involved patients with cardiogenic shock due not only to acute myocardial infarction, but also due to acute decompensated heart failure. And they show an improved survival of 82%. This is replicated by the National Cardiogenic Shock Initiative. Again, here only AMI cardiogenic shock, and from the Japanese registry. And what was uncommon on these trials was the presence of a cardiogenic shock team in their center. So what we have to do? We have to identify cardiogenic shock early. We have to systematically use the pulmonary artery catheter in order to have a right phenotyping of the cardiogenic shock. Right ventricular dysfunction was not really very well understood as an important part of the LV cardiogenic shock or biventricular shock. And of course, we have immediately to understand what is the temporary support we have to apply in order to do aggressive down titration of the inotropes, because inotropes, as we know, portend a high mortality in patients in shock at higher doses. So what is the importance to have a cardiogenic shock team? It's key to improving patients' outcome by early identification and rapid initiation of therapeutic interventions through the establishment of a comprehensive, standardized, team-based approach. These are data from the INOVA trial. They started their shock team in January 2017. They started to collect the data between January and June 2017. They analyzed the data between January and June 2018, and within a 1 year time, they noticed an increase in survival by twice in patient cardiogenic shock due to acute myocardial infarction, and an important improvement in survival in patients in shock due to acute decompensated heart failure. These two slides are from a trial that was published in JACC, I think last year or 2 years ago, and they look at centers in the CCU setting who had a cardiogenic shock team in the dark blue and center who did not have a shock team. And what they noticed, the use of swan guns was significantly higher in the centers that have a shock team. The advanced mechanical circulatory support was higher, the proper MCS for the proper patient in the centers that have a shock team. And believe it or not, CCU mortality was much lower in the centers that have a shock team with statistical significance. When they look at cardiogenic shock to the acute myocardial infarction, non-MI or acute decompensated heart failure overall, they found improved mortality in any of these entities if a shock team was present in the particular center. So this is the contemporary approach to cardiogenic shock. Just to summarize what I described in previous slides, a multidisciplinary shock team, early identification and classification of the shock state. If it's due to acute myocardial infarction, revascularize urgently. Continuous hemodynamic monitoring with the pulmonary artery catheter. Do a right phenotyping of a cardiogenic shock. Choose the right temporary support for the right phenotype and for the right patient. So this is the multidisciplinary shock team at NBI, and the team works together to coordinate prompt communication with referring providers and amongst team members, provide an efficient transition of care from the ED or from the inpatient hospital units to either the cath lab or critical care units, and identify very early patients who are in need for a temporary MCS. So the cardiac shock team is composed of 4 members: advanced heart failure cardiologist, the MCS ECMO or any cardiac surgeon who can place these devices, of course, an interventional cardiologist who is going to intervene right away in an acute myocardial infarction cardiogenic shock by doing PCI supported by Impella CP, and a CTIC intensivist who is going to take care of the patient's post-procedures. And of course, the collaboration for these 4 providers should not stop after we make the diagnosis of cardiogenic shock. They should work together in order to define which patient is going to be able to be weaned from the temporary support as recovery or to be transitioned to another durable support. So how do we choose which device we need? Because we have a lot of devices. We have a lot of Impellas. We have a Impella 5.5 on the horizon right now, and via ECMO. And this formula was not validated by everyone who's used it, because you are going to have a different flow that you are going to set up your ECMO, for example. If you have a 75-year-old woman who is like 50 kilos compared to a 60-year-old male who is 120 kilos. And how you calculate this, you calculate the body surface area. You think the cardiac index of 2.2 should be enough to get me off the shock state, and then you are going to get the run flow. Other centers are doing like 50 to 70 ml per kg per minute. So we have a myriad of devices here. We have all the flavors of Impellas, intra-aortic balloon pumps that is providing only 0.5 liter per minute as augmentation of the cardiac output. You have strict RV support as an Impella RP, and we know that the company came with a new design of the Impella RP. We have the Protect Duo, and of course, even if you have LV isolated cardiac shock or biventricular shock, VA ECMO, it's the one who it's gonna be applied for both situations. We have understands that both VA ECMO and Impella 5 or 5.5 are increasing the afterload, and I'm going to go over this later. I want just to, and I think the Impella talk was very nice prior, but we know that with Impella 2.5 or CP, there is risk of hemolysis, there is risk of pigmented nephropathy and risk of bleeding. And Impella CP is used now only for high-risk PCI, and we don't use this in acute decompensating heart failure cardiogenic shock because of risk of hemolysis. I'm going to talk about VA ECMO. I don't know if you guys had a talk about this, but I'm going to just, if we are going to have later, it's just, you know, an introduction of VA ECMO. And as we see from this graph, for the last 10 years or so, there is an exponential increase of the centers and cases of VA ECMO in the United States. And VA ECMO, it's a bridging strategy. And the indication is cardiogenic shock. We are going to touch upon cardiac arrest or eCPR. But now the VA ECMO is becoming more and more used in patients in shock due to refractory ventricular arrhythmias, or in patients who are going to have very complex ventricular tachyarrhythmias ablation in the EP lab. And also, if the Impella CP is not enough and we have a complex high-risk PCI intervention, VA ECMO can be used. VA ECMO does not replace the cardiac output. It's providing flow to the end organs. So as a consequence, a bridge to something. Most of the time, we aim for VA ECMO to be bridge to recovery, particularly in patients with myocarditis of postpartum cardiomyopathy. Sometimes it's a bridge to decision. If a 75, ended up on the VA ECMO, we have to make a decision. What's the next step for her or for him? But also VA ECMO has an indication if the patient is a proper candidate, either for durable mechanical circulatory support, like an LVAD, or definitive therapy, heart or heart lung transplantation. So ECMO supports the end organ function while heart recovers or not. So it's a bridge to something. These are the guidelines contraindication for VA ECMO: absolute severe irreversible organ dysfunction, and you remember the modifier of anoxic brain injury, or a patient is not a candidate for transplant or for LVAD. Relative contraindication are coagulopathy or contraindication to anticoagulation. We can run VA ECMO up to 1 week without anticoagulation, and limited vascular access. This is called the relative contraindication because you can go anytime to central ECMO if it's needed. So what is the cardiac arrest via ECMO or ECPR? ECPR is the acronym, and there is an application of deployment of ECMO to provide circulatory support in patients who fail to achieve return of spontaneous circulation, or RASC, defined as less or equal of 20 consecutive minutes of CPR. If the use of ECMO was done after achieving RASC, this is not considered ECPR. Can you imagine if you do ECPR in this critical situation, the 50% hospital discharge with full neurological function, it's not great. And the most important determinant of outcome, it's time to basic life support. And I like this graph. So the most important determinant of outcome is the early high quality chest compression, because this is going to determine the success of all subsequent intervention. While it's a cardiac arrest, you have a period of no flow, and this no flow period should be limited to only 5 minutes or less than 5 minutes. When you are starting high quality chest compression, you are going to achieve a low flow state. And ideally, you should deploy the ECMO between the 15 and 25 minutes to start ECMO run within 20 minutes after the cardiac arrest. And as you see here, the longer the duration of the CPR before deployment of the ECMO, the lower the survival is going to be, and the lower the neurological recovery. So this is the inclusion criteria for ECPR, age less than 70, initial rhythm, VFib or VT, witness cardiac arrest, bystander CPR within 5 minutes, and if you do not achieve RASC within 15 minutes of beginning of CPR. Exclusion criteria, asystole, we never place a patient on ECMO on asystole, total cardiac arrest time more than 60 minutes, presence in severe neurological or systemic disorders, acute aortic dissection, contraindication to anticoagulation, the patient is DNR. And this is a meta-analysis of several studies that look at the ECPR versus CPR, and it was shown that by using ECPR compared to only CPR, there is an absolute increase in 30-day survival of 13%, with the number needed to treat 7.7, and there are favorable neurological outcome at 30 days, with number needed to treat 7.1, which are very good numbers. So these are from the NBI policy, so via ECMO contraindications, age more than 70, asystole, severe peripheral vascular disease when the peripheral ECMO implantation is not safe, acute aortic dissection, current intracranial hemorrhage, and if it's an ECPR cardiac arrest, place the ECMO. If the CPR or the cardiac arrest before starting the CPR, I can say it's more than 5 minutes, there is unwitnessed arrest, and the bystander CPR is more than 30 minutes. If you remember, by the guidelines, is more than 60 minutes. So these are the type of cannulation from VA ECMO. Both A and C are peripheral cannulation, and I'm going to explain what is the difference. This is a drainage cannula or the inflow cannula situated at the junction of the inferior vena cava and the right atrium. You have a motor that drains the blood, places an oxygenator, returns the blood to a femoral artery cannula into the descending aorta. In order to keep the leg perfused, you are going to have an antegrade cannula here. So this is also a peripheral ECMO, but here the cannulation is different. The inflow cannula or the drainage cannula, it's the junction of superior vena cava and the right atrium through the JVP. And the return cannula or the outflow cannula is going to be in the subclavian artery or the axillary artery. And why is the advantage of this compared to this? Because this, you are going to oxygenate the brain and you are going to avoid this, what we call northwest harlequin or hypoxemia, differential hypoxemia syndrome. And why do we have differential hypoxemia? And the main contributor to differential hypoxemia, it's the heart recovery with lung, which are still diseased. Because when the heart recovers, the mixing point of the deoxygenated blood from the heart to the oxygenated blood from the ECMO oxygenator is going to be moved more and more towards the diaphragm. And as a consequence, the deoxygenated blood is going to go towards the carotid arteries, into the brain, towards the subclavian and axillary arteries to the arms, and you are going to have a blue upper extremity and a red lower extremity. And because the mixing point is somewhere between the aortic arch and the diaphragm, the best to check the pulmonary artery oxygenation, it's the PO2, the SPO2, and the PO2 in the ABG, it's in the right radial artery. So in order to check the pressure of the oxygenated blood in the ABG, you are going to take a sample from the right radial artery. So I mentioned prior that the ECMO flow, by going back to the descending aorta, it's increasing the afterload. And you have here the pressure volume curves of different ECMO flows. And you can see the higher the ECMO flow, the higher the afterload is going to be. You are going to dilate the heart. You are going to have increased end diastolic volume, right? And because this circuit is bypassing the heart, if you have very poor contractility of the heart, the stroke volume is going to be decreased. The ECMO does not affect heart contractility. So because you increase the afterload, you dilate the heart, you retrograde, you transmit high pressures to the pulmonary circulation, high pulmonary capillary wedge pressure. With pulmonary edema and ARDS, we need to have venting strategies to decompress the heart. The easiest way is to decrease the pump flow. But we don't want to do this because we want to perfuse very well all the end organs. And we want to clarify the lactate as soon as possible. Another way is to use inotropes. But we just went over the fact that the inotropes also have poor survival, particularly used at high doses. Intra-aortic balloon pump is a solution. More and more we move towards Impella 5.5 or Impella to decompress the heart. The Canadians are using atrial septostomy. And the best way to decompress the left ventricle is by placing a LV vent, which is going to be connected to the venous arm of the ECMO circuit. And we can see here from the pressure volume curves that if this is an ECMO flow of 4,500 RPM, right, or 4.5 liters, how I said before, and you place an LV vent, you are going to decrease the end diastolic volume, you are going to decrease the afterload, you are going to increase the stroke volume, and again, the contractility of the heart is not going to be affected. These are the best practices. I mentioned about the right radial A line placement with serial ABG to ensure cerebral oxygenation. I mentioned about the antegrade catheter in order to have the extremity perfused. Serial CPK, lactate level should be checked. We checked also the oxygenation in the both legs and brain when we have patients on ECMO. And also one of the best practice, again, to emphasize, is a pulmonary artery catheter in all VA ECMO patients, because if the wedge is high and the patient is not vented, you are going to have a low threshold to place an Impella or a balloon pump. So this is how you manage the patient. As I mentioned, some institutions are using this formula to calculate the run flow, 50 to 70 ml per kg per minute. We are using in this institution bivalirudin, and Other institutions are using heparin with different goals in terms of ACT, PTT, anti-10A. There are some abstracts at ISHLT this year that compare the benefit of bivalirudin over heparin, and they found superiority of bivalirudin in terms of bleeding and the coagulation of the oxygenator. Ventilatory management, all the time, we have to make sure the patient is ready to be extubated. And of course, we have to use protective ventilation to avoid lung injury, because we have, as I mentioned, ARDS pattern. And most of these patients are going to end up on some kind of dialysis. And we are using the CRRT through the ECMO circuit. And, you know, both limbs of the CRRT should go at the venous limb of the ECMO before the oxygenator. Of course, complications, limb ischemia, but by using the antegrade perfusion catheter, the relative risk reduction it's only 0.41. Stroke, it's a very disabling and sometimes associated with high morbidity and mortality complications. Intracranial stroke, it's 7% in patients who are ECPR. And we have to be very cognitive to try to assess the brain function of any patient on ECMO by weaning sedation. Bleeding, 40%. We can go without anticoagulation for up to 3 days. We've been up to 7 days. And of course, very frequent, it's infection. The longer the ECMO run, the more days you are on ECMO, the higher the infection rate. With more than 53%, more than half of the acquired infection done within 14 days after ECMO initiation, with mortality up to 60%. Sometimes you can have hypercalcitonin in these ECMO patients without to have bacteremia, but this is a sign also of poor prognosis. This is the NBI protocol for cardiogenic shock. Any patients who come in stage C-SCAI cardiogenic shock, either it's due to acute myocardial infarction or acute decompensated heart failure, the shock team is activated. If it's due to acute myocardial, go to the cath lab for rapid revascularization, right heart cath and PAC, and the patient might be supported with intra-aortic balloon pump or Impella CP. If it's due to acute decompensated heart failure, the patient is going to go to either to CCU or CTICU, depends on the severity. An echo can be done, and the echo can be done in the emergency department also. Again, right heart cath, pulmonary artery catheter, very important, inotropes plus minus intra-aortic balloon pump. If despite all these measures, you have this dynamic process, the patients go from stage C to stage D, requiring multiple pressors, even it's on Impella CP or intra-aortic balloon pump, cardiac power output less than 0.6, cardiac index less than 2, lactate more than 4, then you are going to choose your temporary support. And how you are going to choose your temporary support? By phenotyping the cardiogenic shock patient. If you have low filling pressures, you do volume resuscitation. It's hypovolemic shock. If you have high filling pressure in terms of pulmonary capillary wedge pressure, but low CVP, this is an LV dominant cardiogenic shock, you can go either to intra-aortic balloon pump, Impella 5.5. If you do have a right atrial pressure more than 10, pulmonary capillary wedge pressure more than 15, regardless if your PAP is less or more than 2, you aim for biventricular support. And the best biventricular support is via ECMO. You can choose venting either with Impella, either with intra-aortic balloon pump or inotropes as we described. If you have isolated RV support with a high right atrial pressure, with a low edge and low pulsatility index of the pulmonary artery, then you can choose an Impella RP, or you can choose a Protect Duo. If you do have isolated RV support and you need to support the right ventricle, ECMO is not going to work, because ECMO is actually increasing the ECMO is increasing the afterload of the right ventricle. It's going to make it worse. In any situation of this, doesn't matter if you have hypoxemia, you go to via ECMO. If you have a cardiac arrest, the modifier, with no anoxic brain injury, you go to VA ECMO, and this is ECPR that I described before. So this is the NBIMC's volume on to date in 2023. These are data collected from January to April. This is to compare in blue 2022, in red 2023. And you see an increase in volume by 175%, survival to discharge, and survival to decannulation. Numbers of Impella also increased from the previous year on the same time span. But also I'd like to draw to your attention that now we are using more Impella 5.5 on the same time period last year, or 0 Impella 5.5. And the indication for Impella are changing. Now it's other, particularly cardiogenic shock due to acute decompensated heart failure, for patients who are supporting with temporary for heart transplantation. And we have also 2 patients for preemptive Impella 5.5 use for high risk coverage. So in summary, we went over the progress in cardiogenic shock related to pathophysiology, phenotype, and classification. We emphasized the major role of a multidisciplinary shock team in helping the prognostic and survival of cardiogenic shock patients. VA ECMO is an essential MCS in cardiogenic shock. I went over the NBI cardiogenic shock protocol, and I presented the NBI outcome data. Thank you, and I'm happy to take any questions. I see in chat some questions here. Let's see. No, not
Thank
for
you
me.
very much, Dr. Gidea. Let me just check online to see if we have any questions in the chat. I don't see anyone. Does anyone here have any questions they want to ask Dr. Gidea? Yeah, it's just someone saying we. we. Okay, thank you so much, Dr. Gidea. Thank you so much for taking time out of your vacation to, present all this wonderful knowledge to us. We really appreciate it. When you return, let us know, because we have a gift of appreciation, for all your hard work for this presentation, and we really appreciate it.
Thank you. Thank you for inviting me.
Thank you.
It is a pleasure. Thank you.
Enjoy the rest of your time in France.
Thank you.
The next presenter is someone with decades of experience, and her presentation reflects rightfully so. I remember first meeting her in my critical care class, where she taught me all about balloon pumps and CVVH. I wonder why that's what I presented this time. Yeah, the mic's on. So give it up for Peachy, RICAA&M.
Hello, everybody. The last time I was in exact same place was around 5-6 years ago, and the feeling is still the same, unnerving. This right here, this mini symposium, is the best way to culminate our Nurses Week celebration. It's time for us to feed our brain. My topic is not new, however, it's highly relevant because, hold on one second. In our current workplace, we probably have 4 or 5 generations working side by side together. So the age diversity is highly wide. So to start off with our objectives, why don't we identify and focus on the similarities as opposed to the differences? So you may find that we actually have more similarities than we have differences. Secondly, each generation has something great to offer. We all have strengths. So why don't we amplify those strengths and leverage it? And lastly, you may find this a little bit disturbing. Identify and examine your own biases. What do you have, implicit and explicit biases? You may find that those biases you have may hinder you from forging a relationship from somebody younger or older than you. So that's something to think about. Next is our generational cohorts. It's important to remember that these generations can tend to span for about 15 years. And these are a group of people with shared characteristics. And mind you, just because you belong to a certain generation doesn't mean that you exemplify those behaviors and those traits, all right? The one in red, I'm just gonna highlight and make an overview because there's roughly less than 1% of veterans working right now. In terms of Generation Alpha, they're not even in our workforce yet. So to start off, these are our veterans. And I mentioned earlier, there's only 0.7% working currently. Current age for our veterans, 78 to 95 years old. They experience tough times, sacrifices, and hardship growing up. They are also known as silent generation because children were seen, not heard. And they have traditional views in terms of politics, religion, family, hence the term traditionalist. And if you need to know more about this generation, we do have one in C8, Lorelei. Kidding. Kidding. She works in veterans, so she doesn't really qualify. Sorry, Lai. All right, here comes our baby boomers. This is one of the famous generation. So your baby boomers were raised in turbulent times in history. They experienced enormous social change, such as your civil rights movement, women's rights movement, and even anti-war movement. It got its name because of an increase in births after World War II in the tune of 3.4 million births in 1946 alone. Imagine being an L&D nurse at that time. All right, so to continue, current age for our baby boomers, 59 to 77 years old. They ushered an era of divorce, which undoubtedly influenced the future generation. There's a lot of thoughts about that. Firstly, because baby boomers were recognized for their they don't take, how do you call this one? They don't, if they're an unhappy marriage, they're not gonna stick to it. And they're not recognized for pushing boundaries. And another thing is, there was a law that was passed, a Family Law Act in 1969, which basically introduced a no-fault divorce, meaning if one party doesn't want to continue the marriage, they can just go on and end it, and they don't have to provide costs. And these are the characteristics of our baby boomers. One very strong characteristic is their strong and their focused work ethics, because for baby boomers, they define themselves basically by their work. And their self-worth comes directly from their professional achievement. They're the one who coined the word workaholic, and they invented the 50-hour work week. Yay, boomers. They also have a strong sense of community, and they thrive on team environments. Again, these are common assumptions. Doesn't mean that you do have it, so just bear in mind. These are what you call stereotypes. So have you heard about the word okay boomer? That's a catchphrase. And also there's a lot of okay boomer memes in the internet. Those were from Gen Z and millennials because they want to dismiss or mock the attitudes and associated with your baby boomers. Next will be your Generation X. Current age 43 to 58 years old. They are otherwise called the middle child generation because they're in between the famous boomer and another famous millennials. They're also known as the forgotten or overlooked because of small numbers of Gen X. On a political front, your Gen X basically had been raised in the shadow of Vietnam War. And the members of Gen X were more than the boomers. They have more dual income, single family household. And many of the Gen Xers actually are product of divorce. And consequently, the many Gen Xers were otherwise called as latchkey kid because they were left unattended for a short period of time, especially after school, until mom and dad comes home after work. With being a latchkey kids, most of these attributes like being resourceful, independent, and self-reliant can be traced back from that. And also they are the generation who seeks and crave work-life balance. Unlike your boomers, wherein they're sort of workaholic. And also it's good to note that actually the personal computers were actually, this is the first generation who grew up with personal computers, but we are still being labeled as a digital immigrant because we need to adapt and learn from those technologies. We are more ethnically diverse and liberal on our views in terms of social issues. And these are common assumptions for your Gen X. And one of the attributes or assumption that actually stuck is these slackers or being lazy. It could be attributed to the fact that in 1990, Time magazine published an article titled Living, Proceeding with Caution. They essentially describe your young generation Xers as being aimless and unfocused. So that sort of stuff. Being cynical and skeptical, well, there was a study done in 1998 in Stanford University, wherein they did a research for Gen Xers between 18 to 29 years old. And they compared the same identical questions in 3 different time periods, and there is no difference, meaning anybody at that certain age could be cynical and skeptical, not just the Gen X. And now your Y generations. Current age, 27 to 42 years old. The term millennial was actually first used in a book called Generation, published in 1991 by Neil Howe and Strauss. It's a name given to a generation that would become adults at the turn of century, which is year 2000. This is considered the first digital generation. So they are digital natives. So they come of age at the rise of internet and quickly adapted such technology like your smartphones, your social media, and demand entertainment. And again, they are now the largest workforce since 2019. For their characteristic, like your Generation X, they also crave work-life balance, and they're extremely tech savvy. So as you can see earlier, those are the millennials that trying to work on our videos, audios, and all that good stuff. And again, according to US Bureau of Labor Statistics, the millennial will make 75% of our US workforce by year 2030. And in terms of their global community, they really care about the difference of making a good mark in the world as we live in, and their happiness stems from that. The now attitude of the millennials is because they grow up with instant gratification. That's the norm for them, so they expect the same thing in the workplace. And these are the common assumptions for our millennials. Based on my research, it says that millennials' loyalty are fickle because they know their worth and they want great salary to go with that one. However, they value their work environment. So if your organization is not up to par, they will leave the organization. And one thing that, remember the Okie Boomer that restored by millennials and the Gen Zs? Well, the boomers also call them a participation trophy because They're doing bare minimum of job. Again, assumptions, stereotypes. And this is your Gen Zs. Okay, I need your ID, Olivia. Current age, 14 and 26. 14 to 26. Gen Z, they're the most racially and ethnically diverse generation in the US history. And just to clarify, Mr. Obama is nowhere representing the Gen Zers, okay? They grow up with him as our president from 2009 to 2017. And as per my son, this movie, animated movie, Spirited Away, was supposed to be one of the best film of all times. Are you guys familiar with this? Okay. All right. So apparently, the essence of the movie is about the manifestations of fears and anxiety as seen through the lens of that young female lead. And it won an Academy Award for one of the best animated film. And when it comes to the working world, your Gen Zers only represent 5%, but it's growing. That sector is growing. And they grow up with smartphones, social media, along with associated convenience and pitfalls. They are often the trendsetters, trend enders, influencers, and influential. And their characteristics, because of the fast acquisition of knowledge, they actually boasted the business to make a greater emphasis on speed and efficiency. And these Gen Zers, they want to be seen as who they are, authentically are. They want to be heard, supported, and given space and opportunity for them to navigate while they develop their personalities and their professional selves. They also value on cultivating working relationships and flexibility in the workplace. And similar to your millennials, they're the digital natives. These are the common assumptions for your Gen Zers. There's a good thing about having your technology at all times with you, but on the downside, in our world, critical world, that actually can cause a problem because you need to be there 100% watching what's going on with your patient. And if you are being distracted by your phone, you may miss vital parts of what's happening with your patient. So for example, what differentiates a critical care nurse from other disciplines is that you're not there, you are not known for being good in managing cardiac arrest. You are good in preventing cardiac arrest. So that's the differentiation. So your astute knowledge and skills and observation is important. So smartphones, which is in your hand, is actually a distraction. Just an FYI. And here's our generation Alpha. They are currently 13 years old and lower. So there are still nowhere the workplace, but it's good to know what the term is because we're gonna be hearing a lot of this generation going forward. This slide is from Department of Labor. And it shows in here that in 2025, the millennials will be the highest workforce. In fact, based on my calculation, there are gonna be 148 million of them in year 2025. The Xers will be 48 million and the boomers will be like 26 plus. So these are the challenges that we're facing with all this multi-generational workforce. First is your assumption. I did pose this question earlier that it could hinder your relationship to somebody younger and older than you. So, but the first thing is to acknowledge your assumption, and then you're gonna be heading towards resolution. In terms of different worldviews, during our formative years, the environment that we're in, family, culture, your social beliefs are some of the factors that will form your perception or your worldviews. So it's okay to disagree with somebody else because it depends on where you are at the moment. In terms of communication, it's not a one-size-fits-all kind of thing. Like, I'll give you a best example. Like my daughter, we do have a group chat, and she told me, Mom, it's not okay to text me okay. The word K is actually, it tantamount to brush off and being disrespectful. She said the best thing when you text is KK or the word okay. So that's an example of text etiquette 101 and also a reverse mentoring, so to speak. So I learned something from my daughter. And also in terms of communication, I did a quick survey in CA probably a month ago. And I asked them, what's the best way for you guys to get a non-urgent message from work? Email, phone call, what did I say? Texts, and majority said text. So those blast emails that we're giving our employee, they're not reading it. All right, I'm kind of sick and tired of listening to myself speak, so I'm gonna give you a short clip. This is just to put everything into perspective. If Laura is around, Laura, this is not 50 Shades of Grey. How come it's not? All right, so I need the technical support of our millennial.
It was working before.
Generation Z.
You might have to click on it. Oh, it goes to YouTube. Okay. Well, open? Yeah, well, I'm supposed to be the I generation, but Alana's better at this than me.
Why is it not
There's no
coming
more,
up?
yeah. The arrows. We have some technical glitches. Yeah.
I don't know why it's not. It should just play. There we go.
No, I see so much.
Yeah, it's,
You need it.
Okay, let's get it. It's really good.
I'd like to get it to play if I can. If it would let me see the link, I could post it. But I have your actual PowerPoint on the other slide, on the other thumb drive.
Can you like click to refresh it?
I can try, but it looks like the internet is just not.
Here, just hit browse YouTube.
Here we go. Hold on. I gotta.
This is the new Google Pixel Fold, the only foldable phone engineered by Google. It's just as amazing folded as it is unfolded. A tablet-sized screen when you need it.
Let me just make sure it's going over the Zoom though. Where's the, is this the one?
The faces that make up the American workforce have changed dramatically over the past couple of decades. Unlike in past years that generally only had 3 different generations in the same workplace, in contemporary times, that number has increased to 5 or 6 generations in the same workplace. This increase has resulted in workplaces having a wider range of expectations that differ depending on age. That doesn't mean that this shift is a bad thing. According to a 2018 Randstad Work Monitor study, 86% of global workers prefer working on a multi-generational team. Before we continue any further, it should be clarified that every individual born in a certain generation does not necessarily fit into the broad characteristics defining that generation. Broad characteristics cannot be attributed to every individual.
My name is Beth Livingston, and I'm an assistant professor of management and entrepreneurship at the Tippie College of Business at the University of Iowa. Kaleidoscope career model says that there are 3 different things that we care about over our careers, which is that we care about challenge, we care about balance, and we care about authenticity. And that the degree to which we care about each of these things shifts and change over time, just like a kaleidoscope. The 3 colors never change, but the combinations do. And it's an attempt to get us to acknowledge that, you know, people will always care about challenge, balance, and authenticity, but at different degrees. And we can meet people where they are and create policies that allow people to spend their entire careers at the same company getting what they need. Because what we tend to see is, for instance, if you're just new from school, it's challenge, challenge, challenge all the time. And then there's a hypothesized sort of divergence for men and women, where women move into balance before men do because of children-related issues, although that has changed as men have begun to do more parenting. And then authenticity is something interesting, as we see, for instance, men often move into the desire for authenticity in their retirement years. I'm going to leave this career and I'll try to do something that's really me, authentically me, that I care about, that I value. And women who move into entrepreneurial positions often do that from a place of authenticity and balance. You know, there's sort of differentiations there.
Having negative opinions between generations isn't a new idea. In the 8th century BC, Hesiod wrote, "I see no hope for the future of our people. They are dependent on the frivolous youth of today." To this day, generational discrimination continues with jokes like "Okay Boomer" or comments like "Millennials all need participation trophies." In many workplaces, comments like these often get a pass and are not reprimanded as being insensitive or discriminatory like racist or sexist comments are. Leaders in an organization need to take steps to let their employees know that generational discrimination will not be tolerated. Companies that allow workplace cultures that shame generations make it a less inclusive environment for different generations of workers. This can lead to a higher turnover and less competitive ability to hire new employees, both young and old.
If we don't acknowledge that and we put in these blanket policies, we're not going to meet people where they are. We're not going to be able to keep them in our organizations for long periods of time because their needs differ and their needs change and shift. So what I need when I'm 25 years old and I didn't have any children was different than, you know, me at 39 with 2 children, which will be different when I'm 64 and, you know, I'm still excited for different challenges. And so the degree to which you can have flexible policies that almost serve in the sort of buffet style, where people can put together things that help them to do their jobs well, and that acknowledge differentiation without putting a value judgment on that, but your reward is greater, and that you can get people who are committed for longer because they'll feel supported throughout their career. They don't have to leave you to go somewhere else.
Okay, I can't get out. Alana. Okay. No, thank you. All right, so I included a video because it wraps up everything that we learned about the different generations. And then now for our potential conflicts and solution. So we'll start off with the technology. Again, we're gonna have Epic coming. So that's gonna be the best way for us to leverage our digital natives. We can partner them with the less tech savvy. I'm making a general statement, so don't get offended if you already are a tech savvy person, but we can buddy with the boomers and the Generation Xers. So that's the way for us to leverage it. And in terms of different applications, different mode of communication, I think the bottom line is it's really good to know your people, because I didn't realize that people preferred text over emails until I asked them about it. So about the interpersonal dynamics, if you want to know a person, you have to initiate a conversation. That's how open dialogue takes place. And that's how you actually build trust. There's a lot of possibilities. You may find that age doesn't really matter if you don't mind. About the work ethics, I understand that we all have something that we valued. If you value work more than family or half and half, then go ahead, do that. But I think judging people because of how much input you're putting in your work is not gonna make you more workaholic, or is she gonna be less workaholic. It's just like finding a balance. What makes life meaningful for you? And in terms of Generation Z, since they are basically new and just starting, they really need a lot of coaching and they like transparency. You may find that they're gonna ask you a lot of questions because they're navigating their work environment. At the same time, they're growing as young professionals. And one of my favorite is the AACN standards. Are you guys familiar with these standards? I don't want to compete with that. All right, so there are 6 standards. Essentially, what the essence of this is like, these standards, it provides evidence-based guidelines for success. The nurse work environment, if you implement all these 6 standards, you can actually improve patient and nurse outcomes. And there's a lot of survey that was done in the past. And as a background, these standards started way back in 2005. They published the article called Establishing and Sustaining Healthy Work Environments, Journey to Excellence. And then the second edition was published in 2016. They did surveys from 2006 all the way to 2018. And there's a positive correlation in the nurse work environment with the healthy work environment, if you implement that. And then the nurse work environment, with the nurse satisfaction, there's a positive outcomes. If the nurse work environment and also the nurse's intent to stay. So it's great to have all these standards implemented. Since I have time limits, I'm gonna only discuss 2 of these standards. The first one, again, is about skilled communication. You have to be proficient in your communication skills as you are with your clinical skills. So use appropriate mode and type of application for you to reach out to your people. Last one is true collaboration. This right here is what true collaboration looks like. You have the energy of your Gen Zers and your millennials. You have their tech savviness, and you have the wisdom and the experience of your boomers and your Gen Zers. And lastly, intentional mentoring. Be intentional about creating opportunities between members of each generation. To our leaders, mentors, and our teachers, we need to provide these employees an opportunity wherein there is an inclusivity, an opportunity, rich place opportunity-rich place of work wherein they will feel supported, valued, safe, and they're gonna be able to be themselves. And lastly, always, always remember the silver lining. And I'm gonna end my presentation with something I really love. This is the quote of an unknown author. It is to your heart that one can see like rightly, for what is essential is invisible to the eye. Kudos to the education team for a job well done. Sandra, thank you for reaching out wherever you are. And to all of you, thank you for your time, your attention. I'm grateful, honored, and thank you very much. Enjoy the rest of the presentation. He's the star. Any questions? Sure. Well noted, Susan. Thank you.
Our next presenter comes from a very special place, a place where no one is allowed without some bonnets or some shoe covers. It's nice to get a wide variety of presenters because it really opens our eyes to what else goes on in our hospital that's not necessarily in our units. Also give her congratulations because she also just completed her PAS level 4. Give it up from Rita from the OR.
Good morning, guys. This is my first time, so pardon me with the shaking of the voice, okay? I did the rehearsal, but I don't think it's working. But anyways, happy Nurses Week to us, right? Okay, I'm here to present a very special, I call it hospital within a hospital. As she said, you know, not everybody's allowed unless you're wearing green, right? But what I'm presenting here is how we work, what we do, so at least you have a glimpse of how we work with our patients and how we share our knowledge and skills on what we do in everyday living, okay? So this is just a picture of us, all the nurses. So thank you for the iPhone. I made that. And welcome to the OR. This is how we do it. You see all the pictures? That's how technically and how do you say it? Techie savvy we are, especially the generation that's next to my generation. Okay, the objectives of this presentation, I have two. One is to understand perioperative nurses' experiences and accountability in patient care and safety in the operating room. As I said, we're kind of different. You guys are, most of you are on bedside. Ours is on the side of the patient's highest stress and anxiety level, you know, before surgery. The second one is to identify dynamic factors that differentiate periop nurses from other branches of nursing care. Because with us, it's more of a technicality and make sure we know the instruments, the equipments, and all other necessary equipment to make sure patient has a satisfying and safe patient care delivery. For my introduction, this definition comes from one of my alma mater, Western Governors University. Periop nursing is a branch of nursing where patient care is given before, during, and after their surgical experiences. As I said, the highest peak of patient's anxiety level is prior to having surgery. I know some of us, including me, have a surgery already, so we know how it feels to see, like for the first time, me, I've seen, I live in the OR, inside the OR my entire life career. And can you imagine those kids, separation anxieties, those patients who never been in the hospital, who never had a surgery. Can you imagine the anxiety level? So us as a peri-op nurses, we're there to lessen that, at least during the time that they're with us. OR nurses, to be an OR nurse, you have to go through a longer period of training, not like the others in a patient bedside care that after you get hired, you go to the floor, get orientation, follow somebody. Ours is kind of different. Before we go do our patient nurse job, we have to be trained. We have to be trained technically. We have to be trained on how to take care of patients on a different level of development. You know, kids, adolescent, adulthood, geriatric period. So before they even come to us, they have to go through education. My educator, Alicia, they have to get through those technicalities and patient development, growth and development. So at least when they come, when they see there's a kid patient presenting to them, they know at least how to approach them. They have to be, these are the characteristics. They have to be independent and competent in giving specific surgical patient care in all stages of patient's life. As I said, if the patient's a kid, you know, you're gonna have a hard time. You have to play with them. You have to learn how to talk to them and approach them, and otherwise they're gonna jump on you. The ability to provide care while applying technical skills and expertise. We have different kind of equipments that most of us are the only ones who knows it are in the OR people. If we go like, I know guys, some of you borrows some Bovi or some ultrasound, we have to give you some info on how to use it unless you're tech savvy too, and you have been seen it, or you've been seen it, or you have been in the OR, okay? As I said, this expertise requires knowledge on patients' procedural needs, regardless of their age, like having a pediatric surgery, like the orthospine, which is we cater from, I think we cater from 11 years old till 16 or 17. Knowledge on numerous specialist surgical procedures, patients having laparoscopic cholecystectomy versus having laminectomy, versus having lap epi, versus having robotic prostatectomies. Ability to use special equipment such as what I showed you in the beginning on how we do it. Those stealth machine, like we actually want to try and jump in the middle. Maybe we'll be in that different era. It's like a big C-arm, big O-arm that when you go in, maybe will disappear. Kind of like the time machine. And then, as I said, Bovies or the Jackson table, which has 3 different parts that we put apart or put it together. So it's kind of helpful for patients positioning. And then some like the robotic, you have to know how to drape the arms. You have to learn how to drive. I know all of us knows how to drive, but those robotic machines need to be driven carefully and has a technique, okay? Knowing specific instruments to each specialized procedures done in the OR, acting as a circulating or scrub nurse. As a circulator nurse, from the beginning of the case preparation, we have to know, do we have the correct instruments? Do we have the correct equipment? For laparoscopic procedures, basically we need laparoscopic instruments. For robotic, we need robotic instruments. For orthopedic or spine, we need those special instruments. It's very procedure specifics. Although we have our main like basic general instruments, those are basic to almost all of the general instrumentations. In addition to those are the special equipments and instruments for each case. Now, let me present to you the group of people that we work every day. Those are very special team I call family, because with addition or subtraction of one, we cannot be performing our best daily activities, okay? So these are one of the main member of the team, the specialist surgeons. Specialist surgeons, like their specialty for orthopedics, specialty for GYN, specialties for robotics, specialties for ENTs. These are our surgeons, our beloved surgeons. And I thank them for they let me took their pictures. They're really hard to catch up. These are the anesthesiologists. Maybe some of you met them on the floor, especially the peds. These are the people that take care of the patients while they're on sleep. And they're very good in that. And I can attest to that. These are the group of certified nurses. Of course, they're still nurses, but they have a highly skilled certified nurse anesthetist. They are mostly working together. They are working with anesthesiologists next to them, and they are very good. The only thing they don't have on their initials is the word MD. Another group of people, these are the best nurses of NBI operating room nurses. We have multi-generations there. We have Gen X, we have Gen Y, and we have, you know who, the tech-savvy people. And if you really know and feel how we train these people, you know, they have, I should say, I feel grateful that with my service, I'm a service line manager for ortho, spine, neuro, and podiatry and pain management. It's kind of challenging. You can tell the difference between generation to generation. I myself doesn't have that long patience, but as a service line, you gotta learn how to expand longer and longer and longer, or else you're gonna crush. But as I said, these are the group of people that takes care of the people on their highest peak of anxiety. So we learn how to be patient, we learn how to take care of them, and we learn how to love them. Because it's only during their sleeping time that they encounter us. And that's why when I introduce myself to my patient, I always say, I know you won't remember me, but I'll be there with you while you're asleep. Another person, a team of people are the surgical technicians. These surgical techs, nurses, and surgical tech certifieds are the ones responsible to the sterility and their back tables. They're the one who's preparing the instrumentation that's needed in surgery. They're the one who I consider like very good, very specific, like the instrumentation, especially in the second picture, that's very complicated. Some of them are really like very afraid how to approach unless they're comfortable. Those are surgical techs for general surgeries, for orthopedics, for bariatrics and robotics. I just want to share I just want to share with you and show you how they work in the OR. Okay. These ancillary personnel are the anesthesia techs that we always call prior to and after surgery, where they clean up the anesthesia machine and everything, and they're always there to help us, especially in between cases or during cases that we need anesthesia needed help most. The other side of the picture are the ancillary service housekeeping that we make good friends of, because they really go with us with the flow to make sure the turnovers are acceptable. Now, activities, an OR nurse is responsible before, during, and after patient's surgical procedure. Let me wear my glasses. even before we begin the cases of the day, after the huddle of 5 minutes huddle at the front desk at 7 o'clock, 7:05, 7:06 were dismissed. So even before the patient reached the OR room, we're responsible of taking care of them, make sure they're good to go, like lab works are good, there's no issues with any MR number, all our equipment, all our instruments are in the room, and whatever needed to be, like for example, there's potassium or there's a laboratory variations, that needs to be known to everybody part of the team. So at least we can be ready. We would know whether the patient will be safe or we can do the case or not. Is it for the benefit of patient to get canceled, the case get canceled, or are we good to go? Like everything, lab works, loaner trays, everything is available before we even start the case. In the early morning, let's say, my manager always say, or my assistant director always say, have a good day, guys. That means that's the beginning of our day. This one, the first picture presents the case card. The case card is where we put our items, our instruments, our supplies needed for procedure. You can see on the second picture, there's a circulating nurse that's kind of busy. You cannot even talk to them because they have their own roles and how to prepare the room. The surgical tech, who has to check the instruments before we open up. And the same thing, preparing the room. You can see in these two pictures, everybody has their own role. Everybody has their own activities prior to bringing the patient in the room. Everybody, like anesthesiologists in the very back, are preparing, anesthesia meds for induction. The circulating nurse in the middle below picture, opening stuff for the scrub, and the other one checking the equipment, make sure it's working. Same thing here. Those special equipments needed to be prepped, ready, and initialized before we bring the patient in. The count. The count is one of the most important parts of being a circulating nurse, making sure the count is done prior to bringing the patient, before closing the cavity, like for abdominal surgeries, and prior to skin closure. We, basically, most of our surgeries, we count twice to 3 times. Depends on how or what kind of surgery. For laparoscopic procedures, we always count the beginning of everything, every little thing that you have on your table, on your back table. And then at the end of the case, whatever, if we, for example, for lap pulley, if we ended up not opening, then we don't need to count the major instruments, but we need to count everything soft good wise, like the Bratex and the needles and everything other than the instruments, because we really only have 4 ports that I'm hoping no instruments can go in other than, those needed to be used during that case. This is one of the steps, making sure the patients, at the end of the case, we tell the doctor and everyone in the room, surgical count is complete, so everybody can sleep at night. Once the room is ready, circulator goes to same day to interview his or her patient. In this video, I know we have a lot of problems with the patient. We have a lot of things to prepare, and we have a lot of things to make sure we're ready. One of the problems that we have is a language barrier, because most of our patients are, Spanish speaking, Creole, and everything. So I'm going to show you this video on how we encounter and what we do to fix it. I just need the mouse.
Mr. Stanley, good morning. Dr. Martin, how are you? Good to see you again.
Good morning. My name is Alexandra, and I'm going to be one of the nurses in the operating room with you. Can I see your wristband, please? Your first and last name
17.
and your date of birth? Kevin, do you speak English?
No.
Okay, so I will use the language line, okay, to help you. What language do you speak?
French.
Oh, sorry. Thank God for the Marty. Now we can, speak to the patient and their relatives on whatever language they have. Now, I know, as I said, the stress level of the patients is that high on peak before the surgery. So we try to minimize it or at least lessen it by introduction as they go in the OR. Okay, another video to show you.
Katrina, we're here. This is your room. Room 15. Your room's gonna be cold, but we'll give you a warm blanket, okay? Good morning, everyone. Morning. We have here patient Garcia Katrina. Hi, good morning. This is Kevin. I'm Rita. Katrina. Margaret, Marlene. Can you please state your first name, last name, and date of birth for each? What procedure we make today?
Surgery on my back, luminectomy.
MRI number? 1, 2, 3, 4, 5. Account number is 1, 2, 3, 5, 6, 7. Correct. All right.
Thank you. In this video, we prevent like the wrong patient. So we introduce ourselves as soon as they go in. And then in return, we ask if the patient's capable of talking. We ask them their names, their birthdays, and then we read the medical record and what kind of procedure. In this commonness, like introduction and part of the nurses or whoever's in the room versus the patient, at least we know we have the correct patient in the room.
Katrina, we're here.
And this is the part that during anesthesia induction, the nurses stay in side by side with the anesthesiologists and CRNAs. This is where they need help, at least you're there to support them. You can just put the monitors, you can just keep the patient safe by putting belts, and then just there, like when they need help, you can ask, they will ask you to help them with the mask and everything. And then we go from there, the patient go to sleep. Positioning. There's a lot of variations. There's a lot of positioning devices that we have to have in the room. This is a sample of spine surgery. We have to have those gel phones, Jackson table, those special equipments, gel rolls, that we pad the patient's bony prominences because they will be there for longer period of time, So these protective measures, protective gadgets, and instruments, equipments will help us prevent pressure sores. The skin prepping. There's 3 kinds of skin prepping in the OR. One is the so-called ChloraPrep, DuraPrep. The DuraPrep is betadine with alcohol, and then the Hibiclins, which we always use whenever the patient's allergic to betadine. There's ChloraPrep, the basic one that has alcohol and tint, and that's the most commonly used in any surgery, in most of the surgery. Circulating nurse has some protocols to follow prior to doing such tasks. Even the residents can prep as long as they follow this the recommendation. They must wear jacket or sleeves prior to skin prep. They must wear sterile gloves when prepping, especially when I'm doing ortho and neuro. I'll make sure you wear sterile gloves. must start prepping over incision site then away, and then prevent pooling of solution around the area being prepped. If there's an instance that you get pooling, then we can just stop it with sterile towels. So at least it's dry before draping. Surgeon and resident must wait 3 minutes prior to draping, at least 3 minutes prior to draping the area of incision, especially with ChloraPrep, to promote drying of alcohol content of the prep as it is conducive to fire, as we know of. Timeout. Timeout is the most important part before the patient's, before the skin incision. Everybody has to listen, everybody has to be on pause, and everybody has to pay attention on what the circulating nurse as initiated by surgeon. And I want you to hear, this is one of the most, let's say, a very good, a very nice timeout that everybody in the OR always say before the case. It's just more of audio, because we're not allowed to show pictures.
Okay, guys, can we stop what we're doing? We're gonna do timeout now.
Timeout, everyone. We have here patient Kevin Speed, date of birth March 3rd, 1987. MRN number is 123456. Patient of Dr. Martin, consented for laparoscopic cholecystectomy. Patient is allergic to penicillin, so clindamycin 900 milligrams, giving at 7:30 in the morning. Type and screen ordered, so no confirmation needed. Spoke to blood bank, 2 units of blood on hold. Fire assessment is routine. All equipment and supplies are ready and available for use. Is there any questions?
No.
Do we all agree?
Agree.
All right.
I think that's one of the, I've been in different hospitals from Texas to here, but I think this is the best timeout I've ever heard. And I'm proud of it. During procedure, nurse acts as an eye of the tiger, because any break in the sterility, you have to make sure you whisper in that resident or medical student or any other person in the room. Once they break sterility, they have to either change their gloves or change their gown, scrub outside, change their gown and gloves as necessary. On the final phase of surgical procedure, we do debriefing. Debriefing, we present what happened to what happened in the room. The surgeon usually is asked by a circulating nurse, what is the procedure? How's the blood loss? What is the post-diagnosis? And even circulating nurse will announce count is correct. Everybody have their knowledge on what happened, what transpired in that room, which is a very good thing. So at least, because we're the one documenting, we have to make sure whatever the doctor says, what's the procedure, is what we're documenting. In summary, perioperative nurses' main responsibility in the OR is categorized into separate factors in order to provide safe and successful journey of patient surgical experience. The surgical competence of the nurses is, and the possession of technical expertise in any kind of equipment is the #1 thing for us, as well as making sure the patient's safe and patient safe. Knowing and able to work as a team. Of course, everywhere we go, everywhere we work, we have to make sure we know how to be a good member of a team. Teamwork is the core quality of the OR team, to make sure we have it and to make sure that's what we present to the patient. One cannot successfully fulfill her duty without the help of the other, okay? Balance of these two factors will ensure patient successful surgical experience and self-accomplishment in part of an OR nurse. In comparison to other fields of nursing, ability to manage the pressure between these two is the core distinctive characteristic of an effective OR nurse, okay? And for my last statement, I just wanna say, at the end of the day, it is self-fulfilling knowing that you've been part of the team that makes a difference in somebody's life. All right? Thank you very much for listening. and have a good day. Thank you.
Hi, I have the pleasure of introducing our next speaker. She is one of the day shift A&Ms on C8. And she also just, I believe she just got her PAS level 5. So congratulations. Woo. She's a real patient and nurse advocate for on C8, and we really appreciate her. She's a great mentor, and she just great at leading the floor. And she has a favorite catchphrase. You want to work tonight? Here's Gina Lao-Lim.
All right, good afternoon, everyone. I thank you for coming. I know it's almost lunch, but you shouldn't be hungry because there was food earlier. But anyway, okay, let me start. This is not mine, this is not mine. Okay, this is mine. My topic will be intracranial pressure monitoring with the external ventricular device. So this is the external ventricular device setup. Oh, beforehand, my name is Gina. Okay, what's our goal? My goal is each one of you will be able to manage patient in ICU with the EVD, which is extraventricular device, and intracranial pressure monitoring. A professional nurse will be able to set up the EVD and ICP monitoring when needed. Because sometimes when you're in ICU, suddenly the neurosurgeon decides there's no time to waste. You have to do it now, so you have to do it by bedside. And this we did when we were in F3 before, when they started the neuro cases here. And I heard it's coming back. So ICU, CCU nurses, be ready for this, they are coming. And an RN in the critical care area will be able to maintain, care, and monitor EVD and ICP monitoring. You will be able to do also early EVD drainage and have an idea how much is much, and monitor the ICP pressure reading using your monitor. ICU nurses will be able to understand the indication, contraindication, and the importance and the meaning of the drainage and the reading. This is just a little picture. I didn't draw this, I copied. So just focus on the lateral ventricles. This is just your CSF system because this is more for the EVD. So now, why do we care? Well, this hard one, I'm hard-headed, but it's the skull, okay? When you have, the skull is really a rigid compartment. So when there's a problem, it won't allow outward displacement of swollen tissue. So the tendency is for it to swell, and then the brain contents will shift towards the non-swollen side. What are the causes? Causes are there would be distortion and dysfunction of the brain nerve pathway, and there will be severe herniation or displacement of the brain tissue. If the ICU monitor, I can't read this one, how come it's covered? Well, anyway, if your ICP level approaches your mean arterial pressure, that means it's a bad thing. It's close to calling the sharing network, meaning your patient is close to death. So a sustained increase in ICP above 20 mm mercury would result in a poor outcome. Intracranial pressure would be determined by age, the body, and the position. And lying flat, 30-degree angle would be the best one. I don't know, recently I've come across with the neuro cases, they said keep the head of the bed down. I did question that at one point, but the person wasn't really able to tell me why. But really, what you would expect is the angle would be a 30-degree angle head of the bed. For infant, your number would be expected number, would be 1 to 2, adult would be 5 to 7. This is where I belong. Obese, 12 to 18. Now, if your position is really up, you will definitely get a negative number, which is -3 to -5, which is really not correct. So what can increase our ICP? Well, when the patient coughs or you do suctioning, it can at least for like 10 to 15 seconds, that will alter your number. Then when they do Valsalva maneuver, well, there's the number 3, the sexual intercourse. I don't think they'll do that in the unit. Inappropriate positioning. So sustained elevated ICP, meaning like it's 15, like greater than 5 minutes for a long time is not good. So abnormal ICP, which is greater than 15 to 20, 15, some neurosurgeons will still accept it, but 20 millimeter mercury is abnormal. Other nursing interventions too can increase your ICP. What are the conditions that associate with elevated ICP? Here we go, 9. Intracranial mass, brain injury, hematoma, hydrocephalus, brain swelling, subarachnoid hemorrhage, massive brain swelling, coma, hepatic failure also, extreme increase in, this is intracranial pressure, okay? Can give a critical, ICP monitoring can provide critical information for patient management. What does an ICP monitoring tells caregiver? It will provide a neuro assessment. It allows prompt treatment. It also provides a data when clinical examinations is impossible, meaning sometimes patients are sedated, they are on patient barbiturate coma, paralyzed, change in the cerebral blood flow, expansion of the hematoma, the swelling is increasing. And also when there's an ICP increase, it could also mean there's an increased size in the intracranial mass and lesion. There may be now hydrocephalus starting, and then there's a low cerebral perfusion pressure, which can also be diagnosed. And there is overshunting of conditions. So when your ICP and intracranial venous blood pressure are nearly the same, the state of your cerebral blood flow, meaning your cerebral perfusion, can be implied by ICP interpretation. So CPP equals mean arterial pressure minus your ICP. What do you want for a result? You want at least 60 to 70. Below 50 is really inadequate level of cerebral blood flow. So based on your ICP reading, the neurosurgeon might ask, well, we always will get this, expect it for neuro cases, a StatCat scan. And then, or maybe if they need surgical intervention, then they're gonna ask for that. These are just examples of the possible waveform that you'll see, not that we really see it in the monitor. So anyway, just to let you know, like the normal ICP waveform would be looking like A-line. There's a dichrotic notch. The A waveform that they're saying there is a sustained elevation of like 5 to 20 minutes of plateau waves, so that's not good. So what you wanted is a waveform with a dichrotic notch. So always remind, when it's EBD, I always get reminded, even with the setting up and the draining and opening of stock up and everything, I always think of an A-line. So this is the external drainage and monitoring. So it is a temporary drainage of cerebrospinal fluid from the lateral of the brain or the lumbar space of the spine. So it could be the head or your spine. So how does it work? It goes by gravity or by intracerebral pressure. The drain of your CSF depends on the height of your EBD system. how you put it, where you put it, is it leveled or is it not? So it is used for releasing increased ICP, for draining infected CSF, for draining bloody CSF, or when it's after surgery, or monitoring the flow of your CSF. The traditional and oldest type of ICP monitoring is still the same, I think, it's still the same. You insert, the doctor, the neurosurgeon, inserts a catheter to your lateral ventricle, which they call ventriculostomy. Then a continuous fluid conduit is established between ventricle and pressure transducer. It's a device that converts pressure to electrical current placed at the bedside. So what is your marcation when you are doing your zeroing? The transducer are placed at the point level of the center of ventricle system of the foramen of Monroe. Or in short, just think of your ear, the whole of your ear, that's where you go. And then advantages, it can be zeroed anytime, just like your A-line. An elevated ICP can be treated by releasing your CSF more. I just have to mention here, usually the doctors only want 10 ml of CSF. You don't want to go beyond. But of course, there are times when an hour or two, it goes up or down. Going down is not so bad, but when it goes up, you gotta at least let know your neurosurgeon. So what are the risks of having a monitor like this? Well, infection. So that's why sometimes they put their patients ahead of time with antibiotic. So you limit the days of the catheter and the sterility. And also the risk is hemorrhage, especially those patients having liver function problems, increase in cerebral edema, and occlusion of the catheter sensing device, meaning this part. So how can we treat increased intracranial pressure? This is simple, just a short time relief. You don't want this to happen all the time though. Hyperventilate your patient. So if they're on the ventilator, increase the rate of your ventilation. So because an increased PCO2, blood vessels constrict, reduces the blood flow to the brain. So you have to maintain CO2 of 30 to 35, which is in your ABGPH of 30 to 35. Hyperemia and excessive blood flow. What are the drug therapy? Mannitol, the favorite mannitol, because water is extracted from the edematous swollen brain tissues. You also put the patient on barbiturate coma, chemical paralysis. You know why? Because decrease the metabolic requirement of the patient. So all of this will decrease the cerebral blood flow and volume to the brain, and it decreases the demand for glucose and oxygen. You know the Glasgow scale, but we do the NIHS for our stroke. So eyes opening, just make sure though the eyes is not just opening and your patient's alive. Sometimes dead patients have eyes that are open. Just make sure though with the best verbal, the motor skills, a score of 8 or less reflects coma and a need for vigorous interventions. So fluid volume. You gotta maintain a normal volemic state. Intake and output is really closely monitored. And sometimes swan guns or triple lumen for CVP monitoring. Check your wedges, how's the water status of your patient. And monitor the sodium level too, because they are prone to have ADH, diabetes insipidus, and the Cushing syndromes. So the next step would be the surgical intervention. Sometimes they do the skull flap. That's when you see like they have the opening there in the skull. It accommodates the expansion of the brain tissue temporarily, and they're gonna put that back. And then there's the lobectomy. General measures, head of bed, like I said, 30 degrees. Why? Because it promotes venous drainage. CPP decreases when head is elevated, and CPP increases when head is lowered. Neutral position. The neck should be neutral. Don't let the patient just stay on one side with the pressure on the side or on the left or right. Make sure it's a neutral position. Do not hyperextend or hyperflex. Rotation should be avoided because it increases blood volume. You don't really want a lot of blood there in your brain and impede venous drainage. Of course, avoid valsalva valve maneuver. Those patients having constipation or whatever, make sure you give a laxity beforehand. Why? Because it increases intrathoracic pressure. It will decrease the venous return and it will increase the blood volume in your brain. Of course, you have to have oxygen to treat the hypoxia of the patient. Hypoxemia causes cerebral vasodilation. That means it's also increasing blood flow to your brain. Good pulmonary toilet training, meaning please, let's not forget our chest PT, the turning Q2Rs. That's really very important. And when we suction, as much as possible, the less stimulation we do for the patient. Let's not do it so long. So 10 to 15 seconds would be good. Patient and family education. Explain to the patient, why does the patient have this setup? What is the ICP? What should be the head of the position of the patient? Because sometimes they just come in and walk in and adjust your bed, the head of bed, or lower the bed, raise the bed, and the head and the possible catheter replacement. Remember, we have to zero it. So that means that bed will stay that position as long as it is open. I have to emphasize though, when you travel with your patient to CAT scan or any other procedure, or when you wash, when you turn, you make sure you turn off your stopcock towards your patient, because you don't want the movement and everything to cause more complications with your patient. That's why I always advise you guys, you always do the stopcock closest to your patient, because it's where you can see it. So that way you get reminded all the time that you have to open it again. Traveling, you have to turn it off. And when you reach the CAT scan or the x-ray, you open it when the patient is already in the position that he's supposed to be. Then possible need of insertion of shunt should be informed to the family. And I love this one, decreased amount of stimulation. When you are fed up with so much visitors and asking about your patient, you say, we don't really want the patient to be bothered. We want peace and quiet here. So we can talk outside, and let's, whatever questions you have, just don't try to wake up the patient right now. So assessment and interventions. You have to do your neuro, the Glasgow scale, of course, your basic vital signs, especially the respiration. You have to manage the pain. Patient has pain too, even though they can tell you, so you have to manage it. Remember, catheters should be dated and connections should always be checked. You have to record your ICP and CPP and the drainage every hour. For patient with EVD, it's really very important you monitor the drainage every hour. Remember, like I said, you don't want it to be more than 10. Of course, it can go up a little, but you have to check it. And bowel movement, of course, you have to make sure patient has this regularly, and the dressing should be changed and clean. This is just the setup. So I'll go with the setup. So this is just, I know somebody signed, making a sign there. So let me just show this. Towards the patient. The shorter catheter would be towards the patient. The long one would be to the drain. That way, whatever drain comes, it goes down here. I will talk because my voice is loud, okay? I have to emphasize, because people forget, when they zero, they have to zero. You gotta bring this down. You gotta go to zero and make sure one goes towards the earlobe of your patient, and you can use a laser. See this? So it should be in between the bubble. So if you don't have it, just go to Home Depot and buy that stick that they use, and it's fine. Or I mean, I'm not supposed to teach you this, but sometimes you can go like this. All right, but it's more accurate if you have the laser light.
and you have the right level of your patient. So make sure you flash your line. Oh, transducer, because I see so many connections. Sometimes you don't need a lot of connections. Just remove all the other parts of the transducer, the one that you use in A-line. Just get this part, the end part, get a 30 cc isotonic syringe, and you put it here, flush it, don't push, you pull, just like your A-line pressure bag, and then cup it. That way, nobody will be tempted to push or what. Not that it's easy, it's hard. And it's very sensitive. You cannot have bubbles or when there's clot, I have to just remind you, you cannot flush. It's only the neurosurgeon who can do it. And you know how much is used? Only 0.1 ml of MS. But anyway, for the ICP, it's just for the ICP monitoring, you do it, the zeroing like an A-line. Just make sure you're opening with stopcock and everything open to air and check. But if you have any concern, you can call CA and they will help you. And this setup is like supported, like it won't easily clot. But any other concerns, guys? I think you can play with it if you like, ask me and I can show you. Otherwise, I really thank you so much for listening to my lecture. Thank you very much. That's the baby boomer there.
Because we have a patient before that had a lumbar spine.
Yeah.
So is it
You
on the other side?
For lumbar, you just switch it over. Ventricular and lumbar. You see this blue knob? Roll it. It will say ventricular and lumbar. So for the lumbar, where will be your level? It's gonna be on the side of the insertion of the catheter. That's where it's gonna be. Any more questions? No more. Thank you very much.
Okay, before we move on to our next presenter, our last, our best, I just want to remind everyone who's attending via Zoom, do not log off after the presentation. If you want to get your CEUs for attending this whole thing, do not log off. We have to complete a post test and an evaluation afterwards. So please stay on. I'll give you the QR codes. We'll post the links for the QR codes into the chat. So if you want to get your CEUs to get credit for today, you need to complete both, or else you just get a wonderful day of knowledge and no contact hours for it. So this next presenter also celebrated their PAS level 4 yesterday. She's one of our newer A&Ms, but she's been on C8 for a long time, multi-generational, long time. And she's covering a topic of, something that, most units are currently struggle with is, Candida auris and how, us at C8 is preventing it. So give it up for Maria Caballar, AKA Chengbi.
I want this one. Okay, just put here. Okay? Yeah. All right. Good morning, everyone. Okay. It's a pleasure to be here today. I know it's almost 12. Okay, bear with me. I'll make it fast for you guys, okay? But before I start my presentation, which is the emergence of Candida auris in healthcare settings, CA's approach to mitigate the spread of Candida auris, I just would like to acknowledge my co-leadership team, Dawn, Gina, Peachy, and Sandra, because I made this presentation based on the abstracts that 5 of us worked on about C. auris last March for entry for the quality fair. But unfortunately, we were not selected. Yeah, I don't know why. Okay. I know, but in my opinion, Candida auris is a great topic. The fungal crisis is here and globally and desperately needs addressing. Okay. All right. My objectives for these presentations are to understand what Candida auris is and what you need to know. The primary goal is early detection and treatment, to curtail the spread of infection by implementation of safety measures, and to monitor the adherence to the screening process of all admissions and transfers to the unit. I don't have anything to disclose. Okay. Candida auris or C. auris continues to be a major concern for healthcare facilities, particularly in the United States. But what exactly is Candida auris? And why is it spreading? We are going to take a closer look at this significant microorganism. As you all know, New Jersey is a hotspot for this fungus, and healthy officials are renewing warnings because it is resistant to treatment. And the CDC said, nationwide cases have tripled in 3 years. The CDC is tracking the cases across the country. Right now, 2/3 of all infections are concentrated in New York City and New Jersey. The federal health officials are bracing for an even larger number of cases. This fungus is difficult to treat, but easy to spread. Hospitals and healthcare facilities are really stepping up the game on this one. Okay, so what is Candida auris? Candida auris is an evolving multi-drug resistant yeast infection that is regarded with high mortality rate, specifically in patients with underlying comorbidities. C. auris can persist on surfaces in healthcare environments. They remain colonized for many months, perhaps indefinitely. Even after an acute infection, if present, has been treated and resolves, thus leading to outbreaks that can be challenging to manage or control. C. auris does not respond to traditional antifungal drugs, making infections difficult to treat. So it is important to rapidly identify patients who are infected and colonized with Candida auris. An appropriate use of infection and prevention control measures can help to subdue the spread of this yeast, infection in healthcare settings, and control outbreaks. Why is C. auris a problem? First, it causes serious infections. C. auris can enter the bloodstream and spread throughout the body, causing serious invasive infections. More than 1 in 3 patients with invasive Candida infection die, so it is really fatal. There are also other types of infections that can cause C. auris. They are wound infections and ear infections, but they are not as serious as invasive infections. It also has been isolated from respiratory and urine specimens, but it is unclear if it causes infections in the lung or bladder. Second, it is often drug resistant, meaning that is resistant to multiple antifungal drugs commonly used to treat Candida infections, making infections difficult to treat. CDC was concerned of a tripling in 2021 of the number of cases that were resistant to echinocandins. This is the antifungal drug most recommended for treatment of Candida auris infections. I think in C8, it is the casfofungin, right? We're using that for the C. auris. Yeah, that is under the echinocandins. It is becoming more common. Although C. auris was just discovered in 2009, it has spread quickly to more than a dozen countries. In the United States, research has shown that C. auris has appeared in 16 new states since 2019. With instances increasing into 2022, The spread of C. auris appears to be a continuing phenomenon. It is difficult to identify with standard laboratory methods, and it can be misidentified in labs without specific technology. Misidentification may lead to inappropriate management. Specialized laboratory technology or method is used, such as mass spectrometry or what you call a MALDI-TOF MS, matrix assisted laser desorption ionization time of flight mass spectrometry. This is a special lab method. And polymerase chain reaction, or PCR, because it has more rapid and accurate results. Yesterday, during the staff meeting in C8, we discussed about C. auris, and Leon said that we are gonna change the testing of C. auris to PCR now. Okay, and he said probably in a month we are going to start it. Oh, go back. It can spread in hospitals and nursing homes, causing outbreaks. It is believed that the interpersonal contact, as well as contact with contaminated surfaces and areas, appear to play a role in the microorganism's transmission. For this reason, it is important to rapidly identify Candida auris in a hospitalized patient so that healthcare facilities can take special precautions to stop its spread. Let me tell you a little bit of facts about C. auris. C. auris first originated in 2009 from samples taken from a geriatric hospital located in Tokyo, Japan. It has quickly become a cause of severe infections around the world. However, retrospective analysis of isolates identify a C. auris strain from South Korea in 1996. Because the studied samples were originally from the external ear canal discharge of an inpatient, the Candida was named Auris. Auris is the Latin word for ear. Despite its name, C. auris can also affect many other regions of the body and can cause invasive infections, including bloodstream and wound infections. C. auris began spreading in the United States in 2015, and instances of the C. auris in the United States have increased every year since then. Reported cases increased 318% in 2018 when compared to the average number of cases reported in 2015 to 2017. Okay. Let's talk about the risk factors for C. auris infection. Common ones include older age, if you have some sort of nursing home exposure, if you have invasive devices that go into your body, such as tracheostomy tubes, PEG tubes, and central venous catheter. In general, C. auris is not a threat to healthy people. But if you are immunocompromised or neutropenic in some sort of way, and that can increase your risk of having C. auris. If you happen to use a broad spectrum antimicrobial drugs, then that can put you on risk for having this type of infection as well. If you have had a long hospital stay that you are exposed to the healthcare system for a prolonged period of time, that is an increased risk. And then lastly, some other drug-resistant organisms, if you have a risk of having those like Acinetobacter, and then lastly, some other drug-resistant organisms, if you have a risk of having those like Acinetobacter, Pseudomonas aeruginosa, Klebsiella pneumoniae, we have also seen those patients with Candida auris. With the emergence of Candida auris in Newark Beth Israel Medical Center in the beginning of 2022, and its global exponential growth and spread throughout inpatient units, C8 leadership and staff implemented the best practice to prevent and control the spread of Candida auris. First, of course, it is very imperative, adherence to hand hygiene. Good hand hygiene is important because Candida auris can live on surfaces for several weeks. Using alcohol-based hand sanitizer, or AVHS, is the preferred hand hygiene method for C. auris when hands are not visibly soiled, while washing with soap and water is preferred for visibly soiled. Wearing gloves is not a substitute for hand hygiene. PPE utilization, disposable medical supplies, contact isolation protocol through PPE utilization, disposable medical supplies have to be used. Ensure that adequate supplies such as gloves, gowns, masks, alcohol-based hand sanitizer, and cleaning and disinfection agents are available to implement and maintain appropriate infection control measures. In regards to equipment cleaning, usage of non-dedicated, non-disposable medical equipment cleaned only by agility. On enhanced communication, interdepartmental collaboration is also initiated to enhance communication regarding cleaning of medical equipment using Environmental Protection Agency registered disinfectants. I think we are using the Prime. It's the purple color of wipes disinfectants. When transferring patient to other unit or outside facility, make sure to inform them of patients having a C. auris status. Oh, let's go back. I'm not done yet. Okay, disposing of unused supplies. It is important, please limit bringing so much of disposable supplies inside patient's room because you will only dispose them anyways when you don't need it anymore and it's just a waste. Swab all admission and transfers to increase surveillance of new cases. All patients admitted and transferred to the unit are screened and tested for Candida auris. Use of contact precaution until the result comes back. Restrict patients to the room except for medically necessary procedures. Containment is necessary to prevent outbreak. Track and trend hand hygiene compliance. C8 leadership and staff have been vigilant monitoring C8 hand hygiene staff and visitor compliance. And we also audit hand hygiene every day for those people who goes inside and out of the patient's room. Terminal cleaning with UV lights in all rooms. Terminal cleaning with ultraviolet lights in all rooms regardless of isolation status. UV lights provide higher log reductions in regard to C. auris and other epidemiologically significant organisms. Curtain has to be changed as well. Collaboration with infection prevention IP team. Engaging with the IP team is necessary. Periodic testing that is mandated by New Jersey Department of Health is also implemented, which is headed by our infection prevention team. Okay. Adherence to CDC recommendations, collaboration with C8 staff, IP team, environmental services, and agility, these yield the following results. As you can see on the screen, the hand hygiene compliance of C8 on 2022 to 2023, C8 has been outperforming its baseline of 40%, averaging 62% monthly based on 1.8 million events. So this is a good result for hand hygiene compliance. All right. In regards to equipment infection control report on 2022, report showed a compliance rate of 98.8% for the year 2022, with a total of 7,108 assigned equipment. However, there is a violation rate of 1.2% were found to be mostly dedicated to IV pumps. which is 0.9%, meaning reusing IV pump from one patient to another without passing through agility is a no-no. Some equipments are sequential device pumps, 0.13%, bear hugger, 0.07%, feeding pump, 0.03%, hyperhypothermia machine, 0.03%, wound vac, 0.014%, and ICU medical monitor, 0.014%. Oh, these are just the breakdown of the equipments. I don't need to specify everything. Okay. For the UV disinfection compliance report of 2022 in C8, the compliance report in C8 is 96%, which is average rating for 2022. Okay. Despite efforts to control and manage Candida auris, new cases have been identified up to date, and a notable increase of 11 cases in the last quarter of 2022, 3 of which are from C8. You can see on the screen, right? Okay. In first quarter of 2022, out of 3, C8 had 1 case. In second quarter and third quarter, C8 had none, but the whole Bet Israel had 5. Fourth quarter, that's the significant increase, which I told you already. And in first quarter of 2023, 6 cases, 2 of which are from C8. So this is just the breakdown. All right. In conclusion, continued surveillance, education, and application of new strategies are some of the key components to succeed in this venture. Hand hygiene is reinforced with a goal of 70% compliance. The new method of acquiring specimen included swabbing of the nares, armpits, and groins that mimics the testing regulation from New Jersey Department of Health. All patients are also placed on contact isolation. Thank you. And these are the reference. No question, okay? It's 12:04, 4 minutes. Yes, any question? Well, studies show that ear now is less likely to have CRS. It's more on the armpit, the groin, and now it's the nares. But as what Leon said yesterday, it's gonna be the PCR test, right, Leon? And it's gonna be started in a month. Okay, thank you. Thank God, I'm done.
All right, let's give a big round of applause to all our individuals who organized this event. I say this is probably the best way to end Nurses Week is by this symposium, because we do know critical care does put on the best programs. I want to say happy Nurses Week to all of you. I want you to know from the leadership team, we truly appreciate everything you guys do. I want to give a special shout out and thank you to all our presenters today. I know I did learn some things today. Yesterday, I was told I was old, so I did learn some new stuff today. So I won't tell you who told me that. And I hope everyone else learned something today as well. And I look forward next year. Hopefully we can make it bigger, have the entire system want to come to this program. That's our goal. That's my goal. Yes. Correct. Very good. So we're hopeful next year we have more people show up from around the system. And again, this will be the place to come for critical care symposiums. All right. Thank you, everybody. Have a good day.
Okay, thank you to all the senior leadership team that made all of this possible, the education committee, C8, and all that stuff. I really appreciate Don, Leon, all our A&M, Sandra, Chingbi, Gina, and Peachy, for all your help. And of course, above there, I really appreciate having Denise Shepard start this off. Really appreciate it and everything like that. So thank you. Yeah, so all my education committee, thank you for all your help, and big thank you to Alana for really putting all the technical stuff together, helping us with the contact hour application, because that was huge, and also putting up with my nonsense because I'm a really bad procrastinator. So thank you to everyone.